All right, everybody, and welcome to another review for the USMLE Step 2 CK. Today's topic is Hematology and Oncology. Again, these are just my lecture notes or my notes that I did for UWorld. I divided them by chapter or subject matter, and I just wrote down what I thought was the most important and high yield, as the UWorld does, and put it all in one section, and I'm just going to be reading out loud the entire section. So today's topic is Hematology and Oncology, and we're going to get right to it. So Hematology and Oncology, the physiology, we have reticulocytes, which have slightly bluish tint and stain with a methylene blue. Pathological red blood cells and their forms. So you have Howell-Jolly bodies, which are nuclear remnants in the red blood cell, and that typically is removed by the spleen. It indicates a splenectomy and functional hypofunctioning of the spleen due to autosplenectomy and infiltrative disorders of the spleen or splenic congestion. Peripheral blood smear shows a single round blue inclusion on a right stain. So those are Howell-Jolly bodies. Heinz bodies are found in G6pd Deficiency. G6pd Deficiency causes hemoglobin to be oxidized, and it forms insoluble precipitations, and that's your Heinz bodies. So a peripheral blood smear is going to show red blood cells after staining with dyes such as crystal violet. So that's how you look for it. And anemia. So now we're going to evaluate anemia. So anemia starts off with low hemoglobin. After you see the low hemoglobin, there's you want to check MCV, and the MCV can either be low, as in an iron deficiency anemia, or a lead intoxication, or thalassemia, or sideroblastic anemia. It could be high, the MCV can be high, so you'll have a B12 deficiency or folate deficiency in those cases, or the MCV can be normal. Now, if it's normal, you got to check the reticulocyte count. Is the reticulocyte count decreased? Because if it's decreased and you have normal MCV with anemia, then that's probably either a leukemia, an aplastic anemia, an infection, or a medication side effect. But if you have normal MCV and a high reticulocyte count, this is either hemorrhage or hemolysis. So the hemolysis can be either intrinsic or extrinsic. Intrinsic hemolysis can be like inherited defects of the hemoglobin or red blood cell membrane or enzymes. And extrinsic causes could be autoimmune causes and paroxysmal nocturnal hemoglobinemia. So that would be like PNH. So microcytic hypochromic anemia. That's the most common, is going to be iron deficiency anemia. And the differential diagnoses are going to include, for microcytic hypochromic anemia, would be iron deficiency with a decrease in intake or increase in blood loss. So you're either not taking in enough iron or you're just bleeding. This is due to either chronic GI bleed, which is the most common cause in adult males, and in postmenopausal women. You want to look for an occult blood in the stool. There could be also a defective utilization of iron, so this would be like anemia of chronic disease. Also, there could be a reduced globin production. In those cases, that would be like a thalassemia or other hemoglobinopathies that do not respond to iron supplementation. A beta thalassemia minor, that's going to present with modest anemia and hematocrits that range from 28 to 40%. And there's going to be an MCV between 55 to 75. It's common in Mediterranean descent, so always look for ancestry on the vignette. Also, reduced heme synthesis. This could be like lead poisoning or a sideroblastic anemia. These can all be microcytic hypochromic anemias. So we said that the microcytic hypochromic anemias could be iron deficiency anemia, thalassemias, anemia of chronic disease, or sideroblastic anemia. In iron deficiency anemia, you're going to typically see a depressed serum iron level, so obviously low iron, increased total iron binding capacity, so the TIBC is going to be high, and a decrease in the serum ferritin level. So there's going to be low stored iron, which is your ferritin, and there's going to be an increase in TIBC, which is the capacity of the iron to bind. If there's high capacity, that means that those seats could be filled. So there's no iron, then that means that there's more seats to be filled. That's your TIBC. And then stored iron is going to be decreased, so ferritin will be low. In thalassemias, your iron will be either normal or high, and as well as the ferritin levels. So ferritin levels can be either low or high. So in thalassemias, iron isn't really going to be a factor for making a diagnosis for thalassemias. In anemia of chronic disease, you're going to have below normal TIBC. So the TIBC is going to be low. And your ferritin levels can be either normal or increased. In sideroblastic anemia, your iron is going to be either high or normal, as well as your ferritin values. So in iron studies in microcytic anemia, so we're going to talk about the cause, like iron deficiency, thalassemias, anemia of chronic disease, and how's the MCV, the iron, the TIBC, the ferritin, and the TIBC going to be? Is it going to be high or low? So in iron deficiency anemia, your MCV is going to be low, so it's microcytic. Iron is going to be low because it's a deficiency in iron. TIBC, remember the seats are available, so there's going to be increased capacity. The stored iron is going to be low, and the transferrin saturation, which is the iron and with the TIBC saturation, that's going to be low as well. In thalassemias, your MCV is going to be very low. Your iron, however, is going to be high in thalassemias. TIBC is going to be decreased in thalassemias because there's a lot of iron taking up those seats. And stored iron is going to be increased as well. And your transferrin saturation is going to be extremely high. So in thalassemias, that's the pattern. It's almost the complete opposite of iron deficiency, except for the MCV. The MCV on both of them are going to be low. In anemia of chronic disease or inflammatory states like arthritis or any type of chronic inflammatory disease, your MCV is going to be normal or decreased. Iron is going to be low. TIBC is going to be low. Ferritin, however, is going to be either normal or high, and your transferrin, your iron and TIBC saturation, that's going to be either normal or low. Okay, so more parameters here. So just to reiterate, but with some more options, we have MCVs, this time RDWs, the red blood cell count, peripheral smears, how are they going to look like with the peripheral smear, serum iron studies, and their response to iron supplementation, as well as hemoglobin electrophoresis with each individual disease. So here in iron deficiency anemia, or in alpha-thalassemia minor, or beta-thalassemia minor. So in iron deficiency anemia, again, the MCV is low. The red blood cell distribution width, or the RDW, is going to be high. The red blood cells are going to be low. And on peripheral smear, you're going to see a microcytosis and hypochromia. That's why it's called microcytic hypochromic anemia. Serum iron studies are going to be low, so low iron and low ferritin, and again, the TIBC is going to be high. The response to iron supplementation, however, is going to increase the hemoglobin. So there is a response when you give them iron with iron deficiency anemia. It's going to increase the hemoglobin. And hemoglobin electrophoresis is actually going to be normal. Versus alpha thalassemia minor, the MCV, again, is decreased. RDW, however, the distribution width is normal, and the red blood cell count is also normal. On peripheral smear, you're going to see target cells. So remember, target cells with thalassemias. So if you see those target cells on a smear, which is a UWorld question, just go straight for thalassemia in your head. If that's what they're asking you, great. If not, which they're probably going to ask you. This person comes in asymptomatic, and they just had a smear done, and this shows up on the smear, and he's from some Mediterranean descent, and suddenly they're asking you, what do you do? And then you do nothing because they're not complaining of anything. It's an alpha thalassemia minor. But you will see target cells. Serum iron studies in alpha thalassemia minor, they're going to be normal, or there's going to be a high iron and ferritin levels because of a red blood cell turnover. And the response to, there's no response or no improvement when they're given iron. And the hemoglobin electrophoresis is normal here. However, in beta thalassemia minor, the MCV, again, is decreased. So all of them, iron deficiency, alpha thalassemia, beta thalassemia, they all have a MCV that's low. The red blood cell distribution width is also normal in beta thal minor. The red blood cell count is normal. And again, on peripheral smears, you're also going to see target cells. You're also going to see on serum iron studies normal iron or increased iron and ferritin because of a red blood cell turnover, and giving them iron isn't going to be an improvement. So how do you differentiate between them is through hemoglobin electrophoresis. On hemoglobin electrophoresis, beta thalassemia minor is going to have an increase in hemoglobin A2 versus alpha thalassemia minor, it's normal hemoglobin electrophoresis. So that's how you distinguish both of them. Iron deficiency anemia has an increase in red blood cell distribution width, and that is the earlier lab findings of iron deficiency anemia. It occurs in nutritional deficiencies as nutrient levels are available for the red blood cell synthesis. They're going to be variable throughout the day. So those nutrient levels vary throughout the day, and that's going to result in cells of varying size. The red blood cell distribution width is more than 20%. That suggests iron deficiency anemia. So that's high RDW. Normal in thalassemia. So in thalassemia, the RDW is going to be around 12 to 14%. Thalassemias, like beta thalassemia, is more common in Mediterranean descents, and alpha is more common in Southeast Asia. So alpha, Asia, A for A. The majority of alpha and beta thalassemia minor cases are asymptomatic, and it's often an incidental finding, having various degrees of anemia, microcytosis, target cells, and teardrop cells on peripheral smear, as well as an MCV that's less than 75 because it's a microcytic anemia. There's going to be a normal red blood cell distribution width, as well as all cells are the same size and width. So here, versus iron deficiency anemia, the RDW is increased, but not on thalassemias, alpha or beta. Thalassemia minor is often confused with iron deficiency anemia. Both thalassemia traits have a microcytosis out of proportion to the degree of anemia. The hemoglobin is going to be more than 10, and it's going to have disproportionately normal or high red blood cell counts. This typically results in a Mentzer index, where that's the MCV or MCV RBC index is going to be less than 13. Hematocrit is usually hematocrit is usually more than 30% in patients with thalassemia minor. In iron deficiency anemia, they have a low red blood cell count, and rarely it becomes microcytic until the hemoglobins drop to less than 10, or there's a hematocrit that's less than 30. And the Metzner index here is more than 13 for iron deficiency. And remember, the Metzner index is it's a comparison of the MCV over the red blood cell count. Okay, next would be lead poisoning in adults. So risk factors for lead poisoning would be occupational exposure, like lead paint, battery exposures, ammunition, construction. Also, there's plumbing, miners, painting, like we just said, paper hanging, people who use cardboard papers for arts and crafts, so paper hanging, and auto repair. as well, or have an increase in risk factor for lead poisoning. Clinical features for lead poisoning would be GI upset, so abdominal pain, constipation, and anorexia. Neurological problems would be like cognitive deficits and peripheral neuropathy. Non-specific symptoms would be like fatigue and irritability and insomnia, as well as hypertension, motor sensory deficits, and nephropathies. So keep that in mind. And hematological features like anemia. Lab findings, you'll see an anemia on labs, elevated venous lead levels, and elevated serum zinc protoporphyrin levels, as well as basophilic stippling on peripheral smear. So the X-ray fluorescence is used to measure bone lead concentration. So basophilic stippling is constitutionally connected with lead poisoning, so keep that in mind. Lead is readily absorbed via the respiratory or gastrointestinal tracts. So in the respiratory, it would be in adults, the GI tracts in children. And 99% of lead is bound to red blood cells, and they disrupt the hemoglobin synthesis when the levels are more than 80 micrograms. This is going to result in a microcytic anemia, and the treatment for lead poisoning would be chelation therapy. Next topic would be acquired sideroblastic anemia, which is due to a peroxidine-dependent impairment of early steps of protoporphyrin synthesis. INH is a known cause of pyridoxine deficiency, so you want to, whenever you're on INH, like in a TB patient, you want to give them supplemental pyridoxine. Two groups of red blood cell populations for sideroblastic anemia. You have your hypochromic and normalchromic, which is your dimorphic red blood cell population. Iron studies will show a high serum iron level, but a decrease in TIBC, and that differentiates from iron deficiency because of that. So in sideroblastic, you'll have low iron, high TIBC, and in sideroblastic is the opposite. Bone marrow sampling is going to be used to confirm the diagnosis by showing the ringed sideroblast, which is a specific diagnosis in this type of patient. Pappenheimer bodies are iron-containing inclusion bodies that are found within the periphery of the red blood cell, and that results from phagosomes that engulf excess amounts of iron, and that's typically seen in a sideroblastic anemia. Macrocytic anemia is when your MCV is more than 100. So common causes of macrocytic anemia would be, number one is folate deficiency, and number two is B12 deficiency. So both of those are going to give you a megaloblastic anemia due to the impaired DNA synthesis, and that's going to cause an MCV actually that's more than 110 with a low reticulocyte count, macro-ovalycytes on red blood cells, and hyperpigmented neutrophils, where the mean lobe count is going to be more than 5 lobes. Also, anisocytosis, as well as poikilocytosis, which is varying shapes and sizes of the red blood cells. So those are the two most common causes of macrocytic anemia, but there's other ones like myelodysplastic syndrome, acute myeloid leukemias. There's drug-induced macrocytic anemia when there's hydroxyurea, which is also known to cause lupus as well. So hydroxyurea is associated with lupus and drug-induced lupus and with drug-induced macrocytic anemia. Also zidovudine and other chemotherapeutic agents. Liver disease can cause a macrocytic anemia. Alcohol abuse, because that leads to the folate deficiency, number one, as well as hypothyroidism. So all those acute myeloid leukemias, drugs, liver disease, alcohol abuse, and hypothyroidism are all non-megaloblastic causes which cause an increase or a decrease in reticulocyte counts. So in the peripheral blood smear, you'll see a reticulocyte count that are best, which is going to be the best next step in the management, is always going to be the peripheral blood smear, so you can actually see them. If there's an increase in the MCV, then It's either folate or B12 levels. If it's low, if either one of them is low, you need to do further tests to find out which one is exactly the cause. An MCV of 110, of more than 110, is going to favor the megaloblastic anemia, like we said. And vitamin B12, the total body stores of B12 is between 2 to 5 milligrams. The minimum daily requirement of vitamin B12 is 6 to 9 micrograms. So in your body, you have more stores of B12 than you are actually required to take in every single day. So there's less chances of you becoming B12 deficient than you are, let's say, folate deficient. The dietary source is only also found in animal products, so meats and dairies. And deficiencies is, like I said, it's going to take a long time to be deficient. So think of somebody who is a vegan or a pure vegan diet that has been a vegan for more than 5 years. That's going to lead to the deficiency. Now, folate deficiency, that occurs within 4 to 5 months of dietary deficiency. The number one cause of folate deficiency is alcohol abuse. It impairs the enterohepatic cycle and folic acid absorption, and that's going to lead to a development of folic acid deficiency. It can develop into a megaloblastic anemia within 5 to 10 weeks of the alcohol abuse, so very quickly. Some medications like phenytoin, primidone, and phenobarbital are going to impair folic acid absorption also, and then that's also going to lead to a folate deficiency. And that folate deficiency is going to then require you to have folic acid supplementation to prevent the deficiency. TMP, trimethoprim, and methotrexate are also known to inhibit dihydrofolate reductase, and that's going to cause a megaloblastic anemia. Basophilic stippling, due to ribosomal precipitations that form varying sizes of blue granules on the red blood cell cytoplasm. That's a non-specific sign, and basophilic stippling can be seen in lead poisoning, it can be seen in alcohol abuse, or in thalassemias. But basophilic stippling usually is associated with lead poisoning, but it's also found in alcohol abuse and in thalassemias. Now, pernicious anemia, the B12 deficiency, the most important cause is B12 deficiency, and that's due to a neurological deficit and achlorhydria, so low chloride levels. Most common causes of B12 deficiency in patients of Northern European descent. There can be presence of other autoimmune diseases like autoimmune thyroid problems and vitiligo. So if you ever see somebody with vitiligo, they might have a B12 deficiency as well. Pernicious anemia causes B12 deficiencies by two mechanisms. So the first one is by the presence of anti-intrinsic factor antibodies, and that's by definition pernicious anemia is anti-intrinsic factor antibodies. It's autoimmune. And also patients that develop chronic atrophic gastritis is going to lead to a decrease in production of intrinsic factor by the gastric parietal cells. So those parietal cells are going to have a low amounts of production of intrinsic factor. So atrophic gastritis increases the risk of intestinal type gastric cancer and gastric carcinoid tumors by 2 to 3 times over the general population. So in these cases, you want to monitor with periodic stool testing and the presence of blood in the stool. You want to diagnose and confirm with the presence of anti-intrinsic factor antibodies. Like we said before, anti-intrinsic factor antibodies is by definition pernicious anemia. So pernicious anemia and myelodysplastic syndromes are more commonly found in elderly patients that present with pancytopenia and macrocytosis, which is an increase in MCV, differentiated by careful examinations of the peripheral smear and a bone marrow for dysplastic cells. Homocysteine levels are going to be increased in folate and in B12 deficiencies, so high homocysteine isn't really going to differentiate. But MMA, which is methylmalonic acid, is increased only in B12 deficiency. So if you see an option where they're saying this person has a megaloblastic anemia and they want you to find out, well, how do you know if it's B12 deficiency? Then the MMA is going to be high, or they'll put methylmalonic acid levels increased in the labs, and then you have to pick, is this B12 or folate, and it's B12 deficiency. But both have increases in homocysteine. Next is normal chromic normocytic anemias. So you have different types of causes of hemolysis. This would be intravascular hemolysis and extravascular hemolysis. Intravascular hemolysis is due to either microangiopathic hemolytic anemia, like a disseminated intravascular coagulation or DIC, because the hemoglobin is released from lysed red blood cells. It's going to bind to haptoglobin. Then haptoglobin is going to form a haptoglobin-hemoglobin complex that's cleared by the liver. Haptoglobin is then going to be decreased to undetectable levels, and red blood cell hemolysis is going to lead to an increase in lactate dehydrogenase levels. The LDH is going to spill out of the red blood cells when they hemolysize. And also there's going to be an increase in indirect bilirubin. Also, transfusion reactions are found with cause intravascular hemolysis, infections, paroxysmal nocturnal hemoglobinuria, and intravenous RhoGAM immune globulin infusion can cause hemolysis. Now, extravascular hemolysis can be caused by intrinsic red blood cell enzyme deficiencies. Example here would be a G6pd deficiency, which is something that's happening within the red blood cell membrane that's going to cause it to hemolysize. It's largely in the reticuloendothelial system, in the lymph nodes, and in the spleen. There's normal to slightly low haptoglobin and a slight increase in LDH with an increase in indirect bilirubin as well. Hemoglobinopathies can also cause extravascular hemolysis, like sickle cell anemia and thalassemia. Again, these are intrinsic problems within the red blood cells, which was a hemoglobinopathy causing the extravascular hemolysis. Membrane defects like hereditary spherocytosis, hypersplenism, IV immunoglobulin infusion, warm or cold agglutinin autoimmune hemolytic reactions in most cases. So a Coombs test in these cases is performed to confirm the diagnosis. Even if it's negative and the suspicion is high, you want to perform a micro Coombs test to confirm the diagnosis. Remember that the warm agglutinins are IgG and the cold agglutinins are IgM. Think back to that mnemonic in step 1 where IgG and IgM is cold ice cream, and then by default IgG is warm. Some intravascular hemolysis can occur, especially in IgM-mediated hemolysis. So IgM, remember, cold agglutinins. And also infections like Bartonella and malaria can cause extravascular hemolysis because these affect inside the red blood cell membrane. Now, intrinsic hemolytic anemia would be hereditary spherocytosis, would be one of them. Hereditary spherocytosis is an autosomal dominant inheritance, so around 75% it's autosomal dominant, and it's of Northern European descent. It could be autosomal recessive. There could be an autosomal recessive form due to spontaneous mutations, and that causes a defect in the ankyrin gene, which causes an abnormal spectrin protein. So if you see spectrin, ankyrin, most likely they're talking about a spherocytosis there because it has to do with the red blood cell membrane. Clinically, they present with a hemolytic anemia, jaundice, splenomegaly, and on lab findings, there's an increase in the MCHC, which is the mean corpuscular hemoglobin concentration, which just means how concentrated of hemoglobin it is. So these are really bright. Also, they'll have, the MCHC, that's due to a membrane loss and the red blood cell dehydration. There's an increase in reticulocytes, an increase in RDW because they vary in size, and normal or low MCV. On spherocytes can be seen on peripheral smear, so that's an obvious gimme. And the negative Coombs test. There's an increase in osmotic fragility because it's so big that it's very fragile, right? And that osmotic fragility is seen on acidified glycerolysis test. There's an abnormal eosin 5 melamide binding test. So maybe that's something to put to memory. Eosin 5 maleimide binding test. Treatment for hereditary spherocytosis is a folic acid supplementation, blood transfusions, and a splenectomy. And then complications could be like pigment gallstones because of calcium bilirubinate leads to a cholecystitis, and at that point you want to perform a cholecystectomy. Another complication for hereditary spherocytosis would be an aplastic crisis if there's a parvovirus B19 infection. Most common hereditary hemolytic anemias in the Northern European population is hereditary spherocytosis. Hemolysis is going to lead to the hyperbilirubinemia, which is going to manifest itself as dark urine, which is your Coca-Cola colored urine, and jaundice and pigment gallstones, which is due to calcium bilirubinate. The reticulocyte count is going to be either is normally high, in a hemolytic anemia, but if it presents in neonates, they are unable to produce appropriate erythropoiesis in response to the anemia, so that's going to cause a severe anemia with a need to transfuse in neonates because they're unable to regain from that loss of red blood cells. Traditionally, sodium chloride osmotic fragility test has a poor sensitivity, so the acidified glycerolysis test along with an eosin 5 maleimide binding test with flow cytometry is the gold standard of diagnosis right now. So it's not sodium chloride, it's acidified glycerolysis or an eosin 5 maleimide binding test. In cases of cholecystitis, you want to remove the gallbladder, and a splenectomy can also improve gallbladder stones. Complications of a splenectomy, immediate complications would be like hemorrhage, post-op infections, injury to nearby organs. Long-term complications could be like sepsis with encapsulated bacteria, especially strep pneumo. There is a risk of pneumococcal sepsis when you remove the spleen because it is an encapsulated organism. So if there is a strep pneumoniae, then there is a risk of pneumococcal sepsis if it's present 30 years and more after a splenectomy. You want to prevent with anti-pneumococcal vaccines like the conjugate vaccine, also a Haemophilus and meningococcal vaccine several weeks before you do the surgery, and a daily oral penicillin prophylaxis for 3 to 5 years post-splenectomy or until adulthood for pediatric patients. You can give penicillin prophylaxis, lifetime, or antibiotics that are made available at home for immediate treatment of any significant fever, because at that point they are susceptible to those infections. Next would be G6pd deficiency. That's your glucose 6-phosphate dehydrogenase deficiency. And this causes a hemolytic anemia that follows an oxidative stress like infections, sulfa drugs, fava beans. All these are highly toxic and can cause a hemolytic anemia if there is a deficiency of G6pd, as well as a population in Asians, Africans, Middle Eastern descents, often in men, and it's X-linked. Manifestations for G6pd, well, because of the hemolysis, they'll have pallor and fatigue, dark urine, jaundice, abdominal, and back pain. Also, on lab findings, there'll be hemolysis, so low hemoglobin counts. There's going to be an increase in indirect bilirubin, increase in the LDH, lactate dehydrogenase, and a decrease in haptoglobin. Remember, haptoglobin is going to be the scavenger whenever there's hemolysis, because haptoglobin likes to scavenge around looking for spare hemoglobin floating around. So if there's hemolysis, then haptoglobin is going to start going around picking up all the debris, right? So if there's a lot of hemolysis going on, then your levels of haptoglobin are going to decrease because they're being used up. Okay, laboratory findings would be bite cells with Heinz bodies. And that would be, remember, the Heinz bodies are denatured hemoglobin precipitations on the peripheral smear, and they'll have a negative Coombs test. G6pd activity level may be normal during an attack. The management for G6pd is to remove or treat the responsible agent or the condition and to just give supportive care. In the G6pd activity may be used as a screening test, but levels are usually normal during the episodes of G6pd deficiency. During the episode of the G6pd deficient red blood cells, while they're being hemolyzed early on in the episodes, and reticulocytes with normal G6pd levels. So then it's better to retest after 3 months, after an episode of 3 months. Next up is paroxysmal nocturnal hemoglobinuria. This usually presents in the 4th decade of life with the following clinical presentations. So it's an acquired genetic defect that results in lack of the glycosyl phosphatidylinositol anchor, which connects proteins including the CD55 and CD59 to the cell surface. So an absence of the CD55 and 59 from the cell surface is going to activate the membrane attack complex, and that is going to cause a hemolysis. So here in PNH, it's because you don't have that CD55 or 59, you start activating the membrane attack complex, causing hemolysis. So what are some of the clinical features of paroxysmal nocturnal hemoglobinuria, or PNH? So the hemolysis is going to cause fatigue, and that's both intravascular and extravascular hemolysis causing fatigue. The cytopenias are going to be due to an impaired hematopoiesis, and venous thrombosis is going to be intra-abdominal as well as in the cerebral veins. The workup for PNH would be a CBC, a hypoplastic or aplastic anemia is going to be found, as well as thrombocytopenia and leukopenia. There's also going to be an elevated LDH and a low haptoglobin, so that's due to the hemolysis. Also, indirect hyperbilirubinemia is going to be increased. And urine analysis, you're going to see hemoglobinuria, and on flow cytometry, you'll see again the absence of the CD55 and CD59. The treatment for PNH would be to give them iron and folate supplementation. You can also do eculizumab, which is a monoclonal antibody that inhibits complement activation. Patients with hemolytic anemia are going to have a tendency for venous thromboembolism, but the PNH patients are going to be the ones that are particularly at risk, especially because of intra-abdominal and cerebral veins affected. Okay, next topic is sickle cell anemia. So what is the pathophysiology here? It's that it's an autosomal recessive inheritance of the sickled beta globulin mutation in Africans and in Hispanic populations. Clinical features of sickle cell anemia would be a hemolytic anemia. They can present with dactylitis, and dactylitis is actually going to be the earliest manifestation of a vaso-occlusion in sickle cell anemia. 6 months to 2 years is going to warrant a complete workup for a previously asymptomatic sickle cell disease patient. And on pathology, you'll see vascular necrosis of the metacarpals and the metatarsals, and you also see osteolytic lesions on X-ray. Also, other features clinically are going to be the acute vaso-occlusive pain crisis. On lab findings, you'll see a decrease in hematocrit. There's going to be an increase in reticulocytes, and that's going to cause a polychromasia on peripheral blood smear. There's also going to be an increase in serum LDH and an increase in unconjugated bilirubin. Peripheral smears is going to show a sickled red cell, as well as Howell-Jolly bodies. And remember that Howell-Jolly bodies are nuclear remnants that are usually removed by the spleen, but there's a decrease in splenic function. So in that case, you'll see the Howell-Jolly bodies because the spleen's not removing them normally. Management, there's going to be maintenance therapy, which includes vaccinations, giving them penicillin until they're 5 years old, folic acid supplementation, and that's daily in patients to correct the underlying folate deficiency. Hydroxyurea for patients with recurrent vaso-occlusive crisis, as well as management for acute pain crisis would be to give them IV hydration, analgesics, and you can consider giving them a transfusion if needed. Chronic extravascular and intravascular hemolysis is going to be caused by sickle cell anemia. So hydroxyurea is a treatment that works by stimulating erythropoiesis to increase the primitive erythroid precursors, and that's going to increase hemoglobin F. So the question there is, what is the mechanism of action of hydroxyurea? And that it increases hemoglobin F, which is then thereby going to decrease hemoglobin S. Now, this is dose limited because side effects will include myelosuppression, and that myelosuppression includes neutropenia, thrombocytopenia, and anemia, but it's otherwise safe. And an exchange transfusion will be used to prevent strokes, and also it's also one of the primary treatments of strokes in patients with sickle cell disease. It's not reversible. Exchange transfusion isn't reversible, obviously. It prevents further strokes by decreasing the number of sickled red blood cells inside the blood. So what you're just trying to do is just remove all those sickled red blood cells when you're doing an exchange transfusion, because that's the problem, right? It's the sickled cells that get vaso-occluded in places, causing ischemia. So sickle cell trait, what is this? It's a painless microscopic or gross hematuria, and that's the most common renal finding in patients with sickle cell trait. They also have something called hyposthenuria, and this is found in sickle cell disease, and it's also common, but it's less severe in patients with sickle cell trait. The red blood cells sickling in the vasa recta of the inner medulla is going to cause an impairment of the countercurrent exchange of free water reabsorption, and that's going to impair the kidney's ability to concentrate urine. And because of that, you'll have nocturia and polyuria. And less commonly, UTIs may occur, especially in pregnant patients. So in sickle cell trait, the clinical features here that they usually are asymptomatic. So they don't get the symptoms of a sickle cell anemia, and it's more prevalent in Africans, in Middle Easterns and Mediterranean countries, African Americans as well, and Hispanic individuals. There's no change in overall life expectancy with a sickle cell trait. The diagnosis here, you'll see normal hemoglobin, a normal reticulocyte count, normal red blood cell indexes, and morphology. The hemoglobin electrophoresis is going to show both hemoglobin A and hemoglobin S, with the amount of hemoglobin A greater than hemoglobin S. So you'll have some hemoglobin A. Complications of a sickle cell trait, renal complications would be hematuria, urinary tract infections, renal medullary carcinoma, and thromboses can also be a complication causing splenic infarction, especially when there's high altitudes, because there the red blood cell membranes will be more likely to sickle, and venous thromboembolisms as well as priapism. Also, renal papillary necrosis can also occur, causing a massive hematuria, but these episodes are usually mild and they go away spontaneously. And on urine analysis, you'll see normal appearing red blood cells on UA. Distal renal tubular acidosis can also occur, and that's due to tubular damage. So acute severe anemia in sickle cell disease can be caused by either aplastic crisis or splenic sequestration crisis. So in an aplastic crisis, you have an abrupt decrease in reticulocytes, less than 1%, and the key features for an aplastic crisis in sickle cell would be a transient arrest of erythropoiesis, and this is all going to be secondary to an infection. And what's the most common infection that causes aplastic crisis is parvovirus B19. Another cause of sickle cell disease or severe anemia in sickle cell disease would be a splenic sequestration crisis. Here you'll have an increase in reticulocytes and you'll have a splenic vaso-occlusion that can rapidly enlarge the spleen, and it occurs in children, obviously more because they actually have a spleen right before they autosplenect. Aplastic crisis. In patients that suffer from aplastic crisis have no splenomegaly. The anemia is typically severe, so there will be a hemoglobin of less than 6. They'll have pallor, weakness, fatigue, and functional systolic murmurs due to a hyperdynamic blood flow. The white blood cells and the platelets are usually normal, and it's usually before the age of 15, because parvo outbreaks are common in school-age children. The blood transfusion is going to be your mainstay of treatment. Now, in a splenic sequestration crisis, this occurs periodically, beginning as early as infancy. They present with acute anemia, which manifests with increasing fatigue and hypotension in severe cases. There's low to absent haptoglobin levels on laboratory. Now, autoinfarctions of the spleen, patients with sickle cell disease, they can have infarcted spleens within the first 18 to 36 months of life. So the Howell-Jolly bodies are going to be seen on peripheral blood smear. Hence, so the patients are going to be at increased risk of a sepsis from strep pneumoniae, H. influenza, Neisseria meningitis, all the encapsulated organisms. And the vaccinations are going to decrease the incidence of a bacteremia. Despite the vaccination of strep pneumoniae by far remains the most common cause of bacteremia in sickle cell disease patients, and that's usually from non-vaccine serotypes. And patients with sickle cell disease can be prevented from attaining an invasive infection by encapsulated organisms by giving them vaccines. So you can give them the conjugate strep pneumo vaccine and a twice daily prophylaxis of penicillin until they're about 5 years old. Avascular necrosis is seen in up to 50% of patients with sickle cell disease, and that develops up to adulthood. And commonly the affected sites are going to be the humerus and the femoral head. And the pathogenesis here is that the sickling is going to cause a microinfarction, and then that microinfarction can lead to bone hyperplasia. Signs and symptoms with avascular necrosis, obviously they'll have restricted range of motion because of the pain. They'll have a lot of pain with no erythema and tenderness to palpation. They have difficulty bearing weight because of the avascular necrosis, especially of the hip. And treatment would be pain management and limitations of weight bearing. With surgical interventions if the conservative treatments fail. So like joint reconstruction, if that fails, then you'll need surgical intervention. So what's electrophoresis? So in hemoglobin A, hemoglobin S, and hemoglobin F, a hemoglobin A normally is around 99%. There's never any hemoglobin S that's never normal. And hemoglobin F is going to be in concentrations of less than 1%. In a sickle cell disease patient, a sickle cell does not have any hemoglobin A. The majority of hemoglobin is hemoglobin S, so S for sickle. And hemoglobin F would be in decreased concentrations, like 5 to 15%. But remember, as we said earlier, a sickle cell trait, that one's going to have a little bit of hemoglobin A, 50 to 60% actually, but they will have a lot of hemoglobin S, 35 to 45%, and the hemoglobin F concentrations are going to be less than 2%. It's that hemoglobin A that they have that's letting them have less severe forms of the disease. Extrinsic hemolytic anemia is the next topic. So let's start off with autoimmune hemolytic anemia. And this is divided into the warm agglutinins and the cold agglutinin autoimmune hemolytic anemias. So warm agglutinins are caused by drugs like penicillins, viral infections, autoimmune diseases like lupus, immunodeficiency states, and lymphoproliferative diseases like CLL. The clinical presentation would be asymptomatic to life-threatening anemias, and their direct Coombs test is going to be positive with an anti-IgG and an anti-C3, or they can have both anti-IgG and anti-C3. Treatment would be steroids. High dose of steroids are going to decrease the autoantibodies, and splenectomy is used for refractory diseases. So if the steroids didn't work, then go ahead and do the splenectomy for warm autoimmune hemolytic anemia. And for complications are venous thromboembolisms as well as lymphoproliferative disorders. Now for cold agglutinin autoimmune hemolytic anemia, these are caused by infections like mycoplasma, pneumonia, and infectious mononucleosis, as well as lymphoproliferative diseases. So lymphoproliferative diseases can be found in both warm and cold. So that's not really something they'll ask, but the infections like mycoplasma versus viruses, it's just, I remember mycoplasma as cold agglutinins because of my cold plasma, go figure. So there you go. Now, clinical presentations for cold agglutinin autoimmune hemolytic anemia would be symptoms of anemia. They can present with livedo reticularis and acral cyanosis with cold exposure that disappears with warming. The direct Coombs test is going to be positive with an anti-C3 or an anti-IgM, but it's usually not IgG. So in this case, it's IgM. Remember, cold ice cream, right? So treatment is to avoid cold temperatures because the cold is what's causing the agglutination. Rituximab, with or without fludarabine, can also be used as treatment. Complications for cold agglutination would be ischemia and peripheral gangrene, as well as lymphoproliferative disorders. So in a warm agglutinin autoimmune hemolytic anemia, splenomegaly is due to an erythrocyte entrapment, and the reticulocytes are usually present. On blood smear, you'll see spherocytes and microspherocytes. You can see elliptocytes, and you can also see an increase in number of polychromatic cells, like reticulocytes. In a non-hemolytic normochromic normocytic anemia, this would be like a chronic kidney disease or an end-stage renal disease. So in chronic kidney disease, what happens is that there's a decrease in erythropoietin production, and that is going to cause a normochromic, normocytic, hypoproliferative anemia. In that case, then you want to give erythropoietin supplementations, and that's going to cause there to be new red blood cells. Because there's all these new red blood cells being formed, iron is being utilized. So there'll be a rapid depletion of the body's iron stores. Additionally, because of the chronic illness, you can also have a microcytic hypochromic anemia of iron deficiency anemia. And because of the possibility of developing subsequent iron deficiency anemia, that can also cause your iron stores, that also requires your iron stores to be elevated prior to the erythropoietin supplementation. So the treatment of choice in patients with iron deficiency anemia is undergoing dialysis would be to do IV iron prep like iron dextran and other recombinant erythropoietins. Now, all patients with chronic renal failure and a hematocrit of less than 30% or a hemoglobin of less than 10% are candidates for recombinant erythropoietin therapy after iron deficiency has been ruled out. Erythropoietin is also indicated in hemodialysis patients who have symptoms that are attributed to or in part to an anemia. So some of the most common side effects of erythropoietin therapy are going to be like worsening of the hypertension. They can have headaches, and flu-like symptoms, and they can also have red cell aplasia. The headaches is because of the patients who are receiving erythropoietin. There's going to be an increase in rise in the diastolic blood pressure. And the flu-like symptoms are seen also, as well as red blood cell aplasia. But that's rare. Now, bleeding disorders, there's bleeding disorders like clotting defects, platelet aggregation defects, as well as thrombocytopenias. So in a bleeding disorder, let's talk about the clotting defect first. The symptoms here in a clotting defect would be hemarthrosis or deep tissue hematomas. Examples of these would be like hemophilia A and hemophilia B. And on labs, you'll see an increase in the activated PTT, or partial thromboplastin time. In platelet aggregation defects, as well as thrombocytopenias, symptoms can be easy or prolonged mucosal bleeding. There could be ecchymoses, or there could be petechia. For platelet aggregation defects, examples would be like von Willebrand's disease and Bernard-Cillier syndrome. And lab tests would show an abnormal platelet function. In a thrombocytopenia, examples of these would be like ITP or leukemia, and here you'll see just a decrease in the platelet count itself. So the coagulation pathway, just quickly, is starts off as either intrinsic or extrinsic. Let's start off with the intrinsic pathway. So you first damage the surface, and that's going to stimulate kininogen or kallikrein to stimulate the clotting factor 12. 12 is going to be converted to 12A, or activated 12, which is then going to stimulate factor 11, which then stimulates factor 9. Then that factor 9 stimulates factor 10. And then 10A, because every time there's a stimulated factor, it's going to activate that factor. And that activated factor is going to be the one activating the following. So the 10A in this case is going to then go into the common pathway and stimulate prothrombin to become thrombin. Then thrombin is going to stimulate fibrinogen to become fibrin. And fibrin is going to finally become cross-linked and cause there to be a fibrin clot. Now, the extrinsic pathway is a little quicker. Here you have a trauma that activates factor 7. Factor 7 is going to become activated factor 7, and activated factor 7 is going to then stimulate factor 10 to become 10A, and that 10A again is going to stimulate prothrombin to become thrombin. Thrombin converts fibrinogen to fibrin, and then fibrin does the cross-linked fibrin clot. Okay, so what are the two hemophilias? You got hemophilia A and B. They're both X-linked recessive. Here the female carriers can be mildly symptomatic. So clinical features of both hemophilia A and B have delayed prolonged bleeding after a mild trauma or a procedure. There can be hemarthrosis or hemophilic arthropathies. And these can also occur with minor trauma or without trauma, and they can begin during toddlerhood when the child is active and ambulatory. That's when you're seeing the symptoms here, because they're going to have all these bumps and bruises. Intramuscular hematomas as well, and GI or GU tract bleeding. On lab findings, you see a prolonged activated PTT, because hemophilia A and B is intrinsic. And there's going to be a decrease or absent factor 8 for hemophilia A, remember 8A, and factor 9, for B. The mnemonic here is B9, right? Now, treatment is you want to administer factor 8 or factor 9, and you can also do desmopressin for mild hemophilias. Hematuria can cause that Coca-Cola colored urine, and that's common, but renal impairment doesn't really occur. It can affect almost every single organ system and result in long-term complications. Some complications here would be like hemophilic arthropathies. It's a late complication of both types of hemophilia, and it's caused by iron hemosiderin deposition in the joints. So you'll have synovitis and fibrosis within the joint, and it's not exactly caused by a microtrauma. It's other mechanisms that can be involved. It's that deposition of iron and hemosiderin. Signs and symptoms of a hemolytic arthropathy would be like chronic worsening of the joint pain and swelling, and that can result in contractures and limited range of motion. It's more common in patients with recurrent hemorthrosises because it's constantly happening all the time, right? It's a chronic thing, and may be visible on the plain x-rays because it'll light up a lot easier because of the iron. The MRI is going to be a helpful tool in making that earlier diagnosis, and also it characterizes the degree of the joint damage, right? And it cannot be entirely prevented, but the early prophylactic treatment with factor concentrates is going to significantly decrease the developing arthropathies. So next up is vitamin K deficiency. In vitamin K deficiency, the risk factors would be like inadequate dietary intake, such as malnutrition, disorders of fat malabsorption like cystic fibrosis or biliary atresia. Remember, exocrine pancreatic insufficiency is going to cause an impairment of fats and fat-soluble vitamin absorption, and that's going to lead to pancreatic enzyme replacement and fat-soluble vitamin replacement or supplementation. Also, disorders of the intestinal inflammation. Disorders of intestinal inflammation will cause celiac disease or inflammatory bowel disease. Those are some of the risk factors. And decreased productions by bacterial flora, like frequent antibiotic use, is going to cause a decrease in production of that. It's going to wipe out that bacterial flora. Clinical features of vitamin K deficiency: you get your easy bruising. The mucosa is going to bleed easy, as well as the GI bleeding. And lab findings, you'll see a increase in PT and an increase in the INR. However, is going to be a normal PTT unless there's a severe deficiency. Now, remember, those fat-soluble vitamins is the vitamin A, D, E, and K. So the important role in the coagulation is that these act as cofactors for enzymatic carboxylation of glutamic acid residues on prothrombin complex proteins. So the deficiency will cause like a hepatocellular disease, and that's loss of storage sites. So there'll be like no storage sites because of the hepatocellular disease. The liver normally is going to store a 30-day supply of vitamin K. So if your liver doesn't work, then you're already not having vitamin K storages. An acutely ill person with underlying liver disease, like an alcoholic, can become vitamin K depleted in about a week. So they'll be required to have an MPO state and broad-spectrum antibiotics, or MPO states and broad-spectrum antibiotics can also contribute to the quick depletion of vitamin K. And this is going to lead to a decrease in coagulation factors 2, 7, 9, and 10, as well as protein C and S. Initially, this increases the PT, followed by a prolongation of the PTT in newborns who do not receive vitamin K injections. This will cause a severe deficiency, and then the increase in PT and PTT will be seen in mild deficiencies. An increase in PT and a normal PTT is diagnosed by a reversal of symptoms with vitamin K administration. Treatment is that you want to administer vitamin K. You have a deficiency in vitamin K, give them vitamin K. This will rapidly replenish the stores in about 10 hours, 8 to 10 hours. Fresh frozen plasma is going to be used for the management of an acute hemorrhage. So platelet disorders is our next topic. Thrombocytopenia, this is the most common cause. The most common causes of thrombocytopenia are either due to decreased platelet productions or an increase in platelet destruction, right? So in a decrease in platelet production, this is caused by viral infections like EBV, hepatitis C, and HIV. Chemotherapy can cause platelet destruction, myelodysplasia, especially if they're older than 60 years of age. Alcohol use, congenital diseases like Fanconi syndrome, and vitamin B12 or folate deficiency. There's also an increase in platelet destruction, and this is caused by lupus or medications like heparin. ITP, so idiopathic thrombocytopenic purpura, can do it, as well as DIC and TTP. And then you also have your antiphospholipid syndrome, which causes an increase in platelet destruction. Other causes would be that dilutional effect due to the massive red blood cell transfusion and splenic sequestration. So if you give somebody lots of blood, let's say they're a trauma victim or something, they require a long surgical procedure where you're constantly transfusing red blood cells, this can actually cause a dilution of your clotting factors and cause a thrombocytopenia. All right, immune thrombocytopenia. This can occur at any age, and it's most commonly affected by age groups of 2 to 5 year olds. In immune thrombocytopenia, their presentation is that they're going to have a history of a viral infection. They'll have asymptomatic petechiae and ecchymosises. That's going to be the most common. And cutaneous bleeding like epistaxis, they'll have nose bleeding, hematuria, or GI bleeding. On lab findings, you'll see an isolated thrombocytopenia of less than 100,000 cells, and you'll also see a normal hematocrit and a leukocyte count. On peripheral smears with megakaryocytes and no other abnormalities. Treatment in children, if there's only skin manifestations, you just want to observe them. If there's bleeding, you can give them IVIG or you can give them steroids. And usually there's going to be a spontaneous recovery within 6 months. And that's why you want to treat only if the bleeding is continues, regardless of a platelet count. And in adults, the treatment is based on the platelets. So if the platelet count's more than 30,000 and they're not bleeding, you just want to observe them. But if the platelets are dropped less than 30,000 or they're actually actively bleeding, you can also give them IVIG or glucocorticoids. In an autoimmune disorder, you'll have an increase in platelet destruction in the spleen, as well as an inhibition of the megakaryocyte platelet production, and that's due to an IgG autoantibody against the platelet membrane glycoproteins. Common causes of isolated thrombocytopenia, this is a diagnosis of exclusion. Megakaryocytes are going to be seen on peripheral blood smear. Other than the history of a pulmonary embolism, CBCs, and examinations of blood smears, only other recommended tests in patients with presumptive idiopathic thrombocytopenic purpura are HIV and hepatitis C viruses if there's risk factors that exist, as the 5 to 10% of patients with chronic HIV can present with an isolated thrombocytopenia before any other symptoms develop. But before this, it's also important to rule out a pseudothrombocytopenia due to platelet clumping by EDTA, abiciximab administration, or inadequate anticoagulation of blood samples. Bone marrow biopsy may be needed in patients with negative tests as well as unexplained thrombocytopenia. You want to treat the underlying cause, and that can alter the course of the secondary ITP. So always leave splenectomy as a last resort for like catastrophic bleeding or chronic ITP that's refractory to an IVIG or steroids. So if IVIG or steroids don't work and it's just nothing else has worked, then you can do splenectomy. ITP, or idiopathic thrombocytopenic purpura, and immune thrombocytopenic purpura are pretty much the same. Now, thrombotic thrombocytopenic purpura, TTP. So what's this? This is a decrease in the ADAMTS 13, ADAMTS 13. Because of that, decrease in ADAMTS 13 activity, that's going to lead to large von Willebrand's factor multimers, and that's going to result in a diffuse microvascular platelet-rich thrombi. So it could either be acquired, such as an autoantibody, or it could be hereditary. And the clinical features of TTP they're going to have a hemolytic anemia with an increase in LDH levels. There's going to be a decrease in haptoglobin levels with schistocytes, thrombocytopenia, that is also going to cause an increase in bleeding time and a normal PT and PTT. Sometimes there'll be renal failure involved, neurological manifestations, and fevers, and the management would be a plasma exchange. The plasma exchange is going to remove the patient's plasma and replace it with donor plasma. And because of that, that donor plasma isn't going to have any autoantibodies. And because you don't have any autoantibodies in that new plasma, it replenishes the ADAMTS13 that was missing beforehand. So this is a life-threatening condition without emergency plasma exchange. The mortality rate is actually 90% with TTP. It's pretty bad. Decrease in ADAMTS13 causes long chains of von Willebrand's factor to accumulate on the endothelial wall. And what does that do? That traps the platelets and causes the thrombi to be generated in areas that are of high shearing forces, like arterioles and capillaries. HIV is a risk factor, but it's most of the cases are either idiopathic or secondary to a drug toxicity. And the peripheral blood smear is done to check the presence of schistocytes, and as it presents in almost all cases, an absence suggests some other kind of diagnosis. So the diagnosis here is based mainly on clinical and lab findings. A combination of thrombocytopenia and hemolytic anemia in the absence of alternative causes is enough to make the diagnosis and to start treatment with plasma exchange. Next up would be the differences of thrombophilias or deep venous thromboses, and that can either be inherited or acquired. Inherited venous thromboses or thrombophilias would be like factor V Leiden mutations, prothrombin gene mutations, protein C deficiency, protein S deficiency, and antithrombin 3 deficiency. Versus acquired thrombophilias, that would be due to immobilization, surgery, malignancy, and medications. So what are some of the hereditary thrombophilias? So we already stated factor V Leiden, a prothrombin mutation. So let's see, factor V Leiden is the most common in those of white ethnicities, and they have an activated protein C resistance. Now, prothrombin mutations, that's the second most common in those of white ethnicities, and they have an increase in prothrombin levels because of the mutation. Antithrombin deficiency is an inherited form. The inherited form is rare, and the acquired form would be like in DIC, cirrhosis, or nephrotic syndrome. And then protein C or an S deficiency, that's caused by a decrease in inactivation of factors 5A and 8A. If possible, you want to discontinue vitamin K blockers like warfarin before evaluating a protein S level. There's also warfarin-induced skin necrosis, but that's only in protein C deficiency. So the workup for the causes, you need a careful history and physical exam. Testing is recommended in the young, so ages less than 45. So those patients with a first time of unprovoked DVT or pulmonary embolism, and patients with recurrent DVTs or PEs, and patients with unusual sites of thrombi, like cerebral thrombis, mesenteric thrombis, and portal vein thrombis. So those are the ones you want to recommend testing. On lab studies, those are going to include CBCs, a comprehensive metabolic panel, coagulation studies like PT, PTT, and INR, an erythrocyte sedimentation rate as well, and hemoccult stool testing, as well as a chest x-ray, and further testing is going to be based on the results of either of those exams. The absence of clear provoking factors, such as a recent procedure or immobilization in patients with a first episode of venous thromboembolism, you want to refer for age-appropriate cancer screening, like colonoscopy if it's warranted because of their age, or mammography, a chest x-ray in most patients with first episodes of unprovoked venous thromboembolism. Then concerns for occult malignancy, like it's due to a suggestive symptom of weight loss or pain, or recurrent or multiple site venous thromboembolisms. That's extensive cancer screening is then recommended, such as chest CTs, abdomen CTs, and pelvic CTs. Factor V Leiden mutation, most are autosomal dominant point mutations in the gene for that factor V, and that makes the gene unable to respond to activated protein C, which is an innate anticoagulant. So the mutation is then going to lead to a slowed down degradation of factors 5 or 5A, and that's going to continue on doing a thrombus formation. The slow degradation of those factors, especially 8 and factor 5A, acts as a cofactor to degrade factor 8A. Treatments of a DVT is our next topic. So the treatment of a deep vein thrombosis, if it's proximal, such as a popliteal or femoral or lower extremity DVT, then you want to see if it's probably either a pulmonary embolism with hemodynamic instability, or it could be a massive proximal DVT that's extensive from the iliofemoral with severe swelling or limb-threatening ischemia. So if either one of those is the case, then you want to ask yourself, are they contraindicated to receiving thrombolytics? If no, you want to give them thrombolytic therapy, and if there's no improvement, you want to consider a thrombectomy, iliac stenting, or surgical thrombectomy. However, if there are contraindications, again, you want to consider mechanical thrombectomy, iliac stenting, surgical thrombectomies. Now, if they don't have pulmonary embolisms or hemodynamic instability or a massive proximal DVT, you want to ask yourself again, is there any contraindications to anticoagulation? If there isn't, then you want to anticoagulate them until you reach a therapeutic INR of 2 to 3. If there are contraindications to anticoagulation, then you want to do an inferior vena cava filter. And failure of the anticoagulation or a recurrence of a DVT is then going to require them to be anticoagulated regardless and reach a therapeutic INR of 2 to 3. Now, in a hemodynamically stable patient, anticoagulants can be used, such as warfarin or heparin initially, or direct factor 10A inhibitors. These would be like rivaroxaban. So the mechanism of action of rivaroxaban is that it's a direct factor 10A inhibitor. It lasts between 2 to 4 hours. It's a single agent, and there's no need for monitoring, and there is no antidote if they do start hemorrhaging. That's the only drawback with the rivaroxaban. It's all great until that point, that if they start hemorrhaging, there's no way of reversing it. Warfarin, however, is a vitamin K blocker or antagonist that reaches therapeutic effect between 5 to 7 days. So it takes about a week, and in an acute DVT treatment, you want to overlap them with heparin beforehand around 5 days. You do need to monitor the PT and PTT as well as the INR or the prothrombin time more than the other one. And but here there is an antidote, and the antidote for warfarin toxicity, it would be fresh frozen plasma or vitamin K. Now, what are some of the contraindications to anticoagulation? Well, they can have a significant active bleeding or a massive GI bleeding. Also, recent surgeries, but they can be started in hemodynamically stable patients as early as 48 to 72 hours after a surgery. Also, an acute hemorrhagic stroke is a contraindication to anticoagulation. Now, what are some of the indications for rivaroxaban? Rivaroxaban is used in an acute DVT or a PE, or if there's recurrent or refractory to a DVT. So if it keeps happening or if the medical treatment isn't working, then you can give them rivaroxaban. If the patient does not want daily injections such as heparin or has difficulty with dietary restrictions and frequent INR monitoring like warfarin, then you want to consider giving them rivaroxaban. And if it has the same efficacy as low molecular weight heparin and warfarin. Now, inferior vena cava filters, this is sometimes the answer, and it's always an answer choice. So what are the indications? Well, contraindications if there is any kind of contraindication to anticoagulation, or they have recurrent or extending thromboembolisms while the patient is fully anticoagulated, meaning that their INR is between 2 to 3, then you can say, okay, we need to step it up with an inferior vena cava filter. It's placed via a transvenous approach, and it's preferably placed the retrievable filter, and it can be removed when you don't need it anymore. Short-term complications for the filter would be bleeding, infections, and thrombuses at the puncture site. And long-term complications would be if the filter starts to migrate, that would be bad, or erosions into the surrounding structures and recurrent thrombuses, that would also be bad, including one that extends into the inferior vena cava and surrounds the filter. Now, Trisell syndrome, which is a hypercoagulable state that leads to a superficial venous thrombosis at unusual sites like the arm and in the chest, that's associated with a pancreatic, which is the most common, a lung, prostate, stomach, or colon cancers, as well as acute leukemias. If that's the case, you want to perform a CT scan of the abdomen to rule out any possibilities of prostate cancer and then go for further tests to determine if it's because of a lung cancer, prostate, stomach, or colon cancers, or acute leukemia. But if you see any kind of superficial venous thrombosis, like in the arms or the chest, that's Trisell syndrome. Okay, management of provoked DVTs after surgery. So if you have a provoked DVT due to a recent surgery, it's likely to be treated for 3 months. Warfarin and IV unfractionated heparin is started on the same day, and it's preferred long-term anticoagulations for patients with end-stage renal disease, like low molecular weight heparin and rivaroxaban are contraindicated in end-stage renal disease. So if you have any kind of chronic kidney disease patient, they can trip you up and ask you if they can have heparin, low molecular weight heparin, unfractionated heparin, and if that's the case, always go for unfractionated heparin. So the U in unfractionated means, to me, U for urine. So you do not give it to them because of uremia, maybe, end-stage renal disease. That's the way I remembered it. So maybe that can help you. Heparin is also continued for initial 4 to 5 days until the therapeutic INR again has reached 2 to 3. And now, what is the threshold for red blood cell transfusions? So red blood cell transfusion thresholds in terms of hemoglobin thresholds. So if the hemoglobin is less than 7, then a transfusion is generally indicated. If the hemoglobin is 7 to 8, then it's only indicated if there's been a cardiac surgery or oncology patients that have treatment, or heart failure patients. If the hemoglobin is between 8 to 10, then a red blood cell transfusion would be if they have symptomatic anemia or ongoing bleeding or acute coronary syndrome or some kind of non-cardiac surgery. And if their hemoglobin levels are more than 10, there's no general indication for a red blood cell transfusion. So as your hemoglobin goes up, basically the recommendation for giving red blood cell transfusion needs to be more serious. So again, if it's less than 7, it's generally indicated to just give them a red blood cell transfusion. But if it's between 7 to 10, start thinking of more seriously ill patients, like surgery patients, heart failure patients, bleeding patients, symptomatic anemia patients, stuff like that. Until their hemoglobin is more than 10, then don't even give them a transfusion. So what are some of the blood transfusion reactions? So in a febrile non-hemolytic transfusion reaction, which is, by the way, the most common reaction, you have fevers and chills within 1 to 6 hours after giving them the transfusion, so that happens very quickly. And it's caused by cytokines that accumulate during the blood storage. So within that blood bag, there is cytokines that are accumulated. As soon as it's introduced to the body, you have a febrile non-hemolytic reaction. Next one would be an acute hemolytic reaction, and that in itself is a medical emergency. Patients will have fever, flank pain, hemoglobinuria, renal failure due to the immune complex deposition. Then within 1 hour of transfusion, that's when it occurs. So it can trip you up with a febrile non-hemolytic, but in this case, this is a lot more severe. And they also have a positive direct Coombs test, and their plasma is pink. The plasma has free hemoglobin more than 25 milligrams per deciliter. You want to retype and cross-match and show the mismatch. And you have ABO incompatibility as well. And those are possibly due to clerical errors at that point. If there is a ABO incompatibility, then it's because somebody gave them the wrong blood bag, right? So an acute hemolytic anemia or acute hemolytic transfusion reaction, that is a medical emergency, and it happens within 1 hour of transfusion. Okay, so then you have a delayed hemolytic reaction, and that's a little bit less. It's mild fever, hemolytic anemia. And that happens within 2 to 10 days after a transfusion. They have a positive Direct-Coombs test and a positive new antibody screen, and it's caused by amnestic antibody responses. You also have anaphylactic transfusion reactions, and those occur rapidly, causing shock very rapidly. It can cause angioedema, urticaria, and it can cause respiratory distress. So the minute you see that, you're thinking anaphylactic within a few seconds to minutes of the transfusion. So here, this is the quickest one, and it's caused by a recipient's anti-IgA antibodies, as well as anti-IgG antibodies as well. So if you see something that happens within seconds, that's anaphylactic. If you have an urticarial or allergic transfusion reaction, that's urticaria with flushing, angioedema, and pruritus, which is itching, within 2 to 3 hours of transfusion, that's caused by the recipient's IgE antibodies and mast cell activations. And then finally, you have your transfusion-related acute lung injury, which is a respiratory distress and signs of non-cardiogenic pulmonary edema. In that case, you want to see a chest x-ray where you'll see bilateral interstitial infiltrates. But every time you see bilateral interstitial infiltrates, which looks like little fluffy clouds, that's a respiratory distress. And that represents pulmonary edema regardless of whether it is a transfusion, lung injury, or whatnot. It could be an infection. That's what it is. And this happens within 6 hours of the transfusion, and it's caused by the donor's anti-leukocyte antibodies. And the last two transfusion reactions, you have your primary hypotension reaction, which is a transient hypotension that's often in patients taking ACE inhibitors. This happens within minutes after the transfusions, and it's caused by the bradykinin that's found in the blood products, which normally is degraded by the ACE enzyme, right? The angiotensin converting enzyme. And so if they're on ACE inhibitors, you can't break it down, so they have a hypotension reaction because of the bradykinin. Bacterial sepsis, so they'll see fevers, chills, septic shock, and DIC within minutes to hours. This also could be, can look like an anaphylactic one as well, so be careful there. Or it could also be could look like an urticarial, an anaphylactic, or it can look like bacterial sepsis. So all those look very similar. And adverse reactions to blood transfusions occur despite multiple tests and inspections of blood. So don't let that fool you in the vignette. So then again, as a recap, transfusion reaction timeline, anaphylaxis is going to be within seconds to minutes. An acute hemolytic reaction is going to take between minutes to 1 hour. A febrile non-hemolytic or a TRALI is going to take between an hour to 6 hours, and then the delayed hemolytic is going to take up to 10 days. So a febrile non-hemolytic is blood that's stored, and the leukocytes are going to release cytokines, and then that gets transfused, and then you get your fevers, your chills, and the malaise. Prevention is to use a leuko-reduced blood product, and the treatment is to stop the transfusion to exclude other serious reactions. You want to administer antipyretics, and you want to avoid aspirin in thrombocytopenic patients, and then use a leuko-reduced blood in the future. So an acute hemolytic reaction, signs and symptoms would be discomfort at the infusion site, and the management would be immediate cessation of transfusion while maintaining IV access for fluids like normal saline and supportive care. in a delayed hemolytic reaction, and that's due to amnestic antibody responses to red blood cell antigens, to which people have previously been sensitized to. Antibodies are undetectable prior to the transfusion, but reappear rapidly following the transfusion. And they have a low-grade hemolysis, and no treatment is usually required with delayed hemolytic reactions. Now, anaphylactic reactions, they have hypotension, difficulty breathing, and that can lead to a loss of consciousness, shock, and respiratory failure. So the management is to stop the transfusion immediately, give them IM epinephrine, circulatory and respiratory support with vasopressors and mechanical ventilation. And you want to give them antihistamine or histamine blockers, and glucocorticoids should also be given. And future transfusions would be an IgA deficient plasma and washed red blood cell products. Next up is indications for specialized red blood cell treatments. So some of the indications for specialized RBC treatments would be like irradiated, leukoreduced, or washed. So irradiated would be like a bone marrow transplant recipient, an acquired or a congenital cellular immunodeficiency. Blood components donated by the first or second degree relatives are all irradiated indications. Leukoreduced indications would be chronically transfused patients, CMV seronegative at-risk patients like AIDS patients or transplant patients, and potential transplant recipients. Also, previous febrile non-hemolytic transfusion reactions are all leukoreduced indications for specialized RBC treatments. Finally, washed indications would be IgA deficiency, complement-dependent autoimmune hemolytic anemias, because the washed red blood cells are used to remove as much plasma as possible because it contains proteins that includes IgA that can cause an allergic reaction. And also continued allergic reactions like hives with red blood cell transfusions are done despite antihistamine treatment. The hemolytic anemia is washed to remove as much plasma as possible as it contains proteins including IgA, and it can also cause an allergic reaction. For leukoreduced, this reduces the number of transfused leukocytes through filtering it or other methods like saline washing, freezing, and deglycerolizing, or a buffy coat removal, basically. It also reduces the risk of HLA alloimmunization as well as transmission of CMV. That's when you leukoreduce the blood products. Calcium gluconate infusion is used to avoid or treat severe hypocalcemia following a massive transfusion. This especially occurs in patients who have received equivalent of more than one blood volume of blood transfusion or packed red blood cells over a 24-hour period. It occurs because of the presence of citrate, which chelates calcium and magnesium inside the plasma, and it's used as an anticoagulant in whole blood used for transfusions, and that can cause paresthesias. So that's why you give a calcium gluconate infusion when you're having lots and lots of blood products being given. And warming to warm the blood bag before you give it to them is used when there's massive blood transfusion needed, and that prevents hypothermia. You want to maintain the blood temperature at body temperature. So next topic is carbon monoxide poisoning. Features of carbon monoxide poisoning are mild, moderate intoxication versus severe intoxication. So for mild, moderate intoxication, they get headaches, that's the most common, confusion, also malaise, dizziness, and nausea. For severe intoxications, here you have your seizures, syncope, coma, myocardial ischemia, and arrhythmias. But mostly for carbon monoxide poisoning, they'll present with a patient with headache. Causes of carbon monoxide poisoning would be smoke inhalation. That's the most common cause. Also, defective heating systems and a use of fuel-burning appliances or motor vehicles in poorly ventilated areas. So they'll give you a person who ran their car inside of the garage, or they're actually using some kind of gas heater to heat their homes. The diagnosis of carbon monoxide poisoning would be to get a carboxyhemoglobin level, as well as to check EKG in all patients. You also want to measure cardiac enzymes in the elderly and in those with cardiac risk factors or signs of ischemia. For the treatment of carbon monoxide poisoning, you want to give 100% oxygen through a non-rebreather face mask. Now, non-smokers have low levels, less than 3% of carboxyhemoglobin, and that's due to normal enzymatic reactions. Cigarette smokers can have levels as high as 10%, and that's with a little exposure to carbon monoxide, and that would cause asymptomatic carbon monoxide poisoning. Carbon monoxide also shifts the oxygen dissociation curve to the left, and that will then cause an inability of hemoglobin to unload oxygen at tissue levels, leading to kidneys producing erythropoietin and then causing secondary polycythemia. So you have high levels of erythropoietin with carbon monoxide poisoning. And the diagnosis is used with a pulse oximetry, or pulse oximetry cannot be used to differentiate hemoglobin that's oxygenated from hemoglobin that has carbon monoxide. So the diagnosis is actually made on arterial blood glasses with carbon monoxide oximetry. So it's very specific. For frostbite, this is our next topic. Frostbite clinical findings would be superficial pallor and anesthesia with blistering, eschar formation, as well as deep tissue necrosis and mummification of the area. And the management for frostbite would be to rapidly rewarm them in temperatures of 98.6 to 102.2, which is around 37 to 39 degrees Celsius. And that's the water has to be at that temperature with a water bath. Analgesia and wound care, also if they have pain, and also thrombolysis if there's severe cases with limb-threatening cases. Frostbite is due to freezing of the tissue, and that causes disruption of the cell membrane, leading to ischemia, vascular thrombosis, and inflammatory changes. And affected tissues typically have stiff or a waxy texture. And most affected parts, like the face, the ear, and the distal limbs, are affected. So rewarming should not be done if there is risks of refreezing before a definitive care can be provided, because it can actually worsen the tissue damage. So you want to give aggressive analgesia to provide pain relief during rewarming, because rewarming can cause a lot of pain. Hot air rewarming is not recommended. You want to remember, immerse them in water that's warm. And in the field, rewarming can be done with holding the affected limb against the rescuer's abdomen. CCBs are not indicated in acute frostbite, but CCBs are used in Raynaud's syndrome. So the next topic is going to be multiple myeloma. And in multiple myeloma, the pathophysiology here is a monoclonal plasma cell proliferation. The manifestations of multiple myeloma would be like bone pain, fractures. There's constitutional symptoms like weight loss and fatigue, and recurrent infections. On labs, you have a normocytic anemia. There's renal insufficiency as well as hypercalcemia. And that hypercalcemia leads to fatigue and constipation as well as depression in multiple myeloma. So if you see that, fatigue, constipation, depression, renal insufficiency, that could be multiple myeloma. And something called, on labs, they can also have monoclonal paraproteinemia, which is a form of hypogammaglobulinemia. On radiology, you'll see osteolytic lesions as well as osteopenia, so that's due to the osteoclast activation. Also, there's bone marrow infiltration by plasma cells, hyperviscosity syndromes that are rarely present in these patients. Respiratory and UTIs are going to be common infections, so respiratory would be like strep pneumonia infections.
In multiple myeloma, on labs, there's a protein gap. The difference between a protein and the total protein and the albumin is going to be more than 4 grams. And that means that there's an increased non-albumin protein in the serum, and that's seen in a polygonal gammopathy. So they'll have infections, connective tissue diseases, or excessive monoclonal proteins like multiple myeloma, as well as Waldenstrom's gamma globulinopathy. SPEP, which is a protein, is a serum protein electrophoresis that it's the most common screening test for multiple myeloma, the SPEP. You'll see the M spike, which is either an IgG or IgA M spike, to identify whether it's monoclonal or polyclonal proteins. Bone marrow biopsy is more invasive, and that confirms the diagnosis when you see more than 10% clonal plasma cells. That leads to a preformed only after gathering more information from peripheral blood smears. You'll see the Rolliot formation, as well as serum-free light chain analysis and SPEP and urine protein electrophoresis. And bone scans are going to show only osteoblastic activity, as in some tumors, so it's not useful for diagnosing multiple myeloma. That's why bone scans are not good. And skeletal survey is going to be more important. Next up is Waldenstrom's macroglobulinemia, and this is a rare chronic disease of a plasma cell neoplasm. It's characterized by abnormal plasma cells which multiply out of control and invade the bone marrow, lymph nodes, and they invade the spleen. Typically, there's also a production of excessive amounts of IgM antibody in the blood, which causes hyperviscosity, thickening of the blood. And the IgM is easy to remember because it's the letter, if you put it upside down, it's a W. So Waldenstrom's would be IgM. So there you go. The following are major signs and symptoms of the disease. So there's 7 things that they can have. They can have increased size of the spleen, liver, and some lymph nodes. They can present with tiredness, and it's usually due to the anemia because there's too few red blood cells. They can have a tendency to bleed and bruise easily. They get night sweats, headaches, and dizziness. There's various visual problems like retinal vein engorgement due to hyperviscosity. And then pain and numbness in the extremities due to a predominantly demyelinating sensomotor neuropathy. Okay, next up is going to be leukemias. There's lymphadenopathy. It can either be benign and malignant. So benign would be a small, less than 1.1 centimeter mobile rubbery nodule that's most often occurs in upper respiratory tract infections. So you want to observe, and if it grows in size or any kind of symptoms develop, then you want to further evaluate that. And this type of leukemia is very common in children and young adults. So we're talking about lymphadenopathies. So they're either benign or malignant. Malignant lymphadenopathy would be if it's more than 2 centimeters, firm, if it's not mobile. It's also found in elderly patients or smokers. Any of those criteria that raises the suspicion of malignancy and of granulomatous disease. Next up is lymphoid neoplasms. So the first one would be ALL, acute lymphoblastic leukemia. And in acute lymphoblastic leukemia, the epidemiology, it's the most common form of childhood cancer. Its peak age is between the ages of 2 to 5 years old, and there's greater prevalence in males than in females. So ALL is the most common childhood cancer. Its peak age is between 2 to 5 years old, and it occurs more in males than in females. Clinically, they have nonspecific symptoms. They have bone pain, lymphadenopathies, hepatosplenomegaly. They can have pallor from anemia and petechiae from their thrombocytopenia. The diagnosis for ALL is through a bone marrow biopsy with more than 25% lymphoblasts, and the treatment for ALL is multi-drug chemotherapy. So patients with Down syndromes are also at increased risk for ALL. Half of patients with ALL may have leukocytes of less than 10,000, but more than 20% of them have leukocytes that are more than 50,000, so that's not very specific. 30 to 50% present with infections, and half of them with lymphadenopathy, as well as hepatosplenomegaly. The lymphoblasts are going to cause a lack of peroxidase positive granules, and that's positive in myeloblasts, but it's positive in cytoplasmic aggregates of PAS positive material. Immunostaining for terminal deoxyribonucleotide transferase, or TDT, is positive, so they have TDT positivity in 95% of cases, and it's only pre-B and pre-T lymphocytes which express the TDT positivity. Next up is chronic lymphocytic leukemia, and in chronic lymphocytic leukemia, the diagnosis clinically would be lymphadenopathy. They can have cervical lymphadenopathy, supraclavicular or axillary lymphadenopathy. They can have hepatosplenomegaly, as well as mild thrombocytopenia and anemia, and they're often asymptomatic. The diagnosis here would be severe lymphocytes and smudge cells on lab smear, and flow cytometry, which can show clonality of the mature B cells. Lymph node and bone marrow biopsy isn't generally needed. So the prognostic factor for CLL the median survival is about 10 years, and the worst prognosis is when they have multiple chain lymphadenopathies, if they have hepatosplenomegaly or anemia and thrombocytopenia associated with their CLL. And the complications of CLL would be like infections, number one, followed by autoimmune hemolytic anemia, and secondary malignancies such as a Richter transformation. Next up is hairy cell leukemia. This is also known as a leukemic reticuloendotheliosis. It's a B-cell derived chronic leukemia, causes pancytopenia, and 10 to 20% can have leukocytosis. This was pretty easy. Hairy cell projections of the lymphocytes causes it to be trapped inside of the red pulp of the spleen, and that causes splenomegaly. Bone marrow becomes fibrotic, and there's a dry tap seen. It's tartrate-resistant acid phosphatase. That's positive to stain. It's a CD11C marker. It's relatively specific for hairy cell leukemia. And it's a benign course as compared to other types of leukemias. And the treatment here would be cladribine, which is a purine analog, 2-chlorodeoxyadenosine, and 2-CDA, which is toxic to the bone marrow, and the side effects can include neurological and kidney damage. So chlorambucil and prednisone, that's used for CLL, and the CHOP regimen is used for non-Hodgkin's lymphoma. So what you need to know for hairy cell leukemia is going to be the tartrate-resistant acid phosphatase stain and maybe the CD11C marker, since it's specific for hairy cell leukemia. They'll also give you a slide. It'll show the hairy projections on the slide. Next up is myeloproliferative disorders.
So under myeloproliferative disorders, you have chronic myelogenous leukemia, and that could be subdivided into leukemoid reactions or chronic myeloid leukemia, or CML. So here in leukemoid reaction, leukocyte counts is more than 50,000, but in CML, the leukocyte count is over 100,000. The causes of a leukemoid reaction are usually just severe infections, versus CML, which is a BCR-ABL fusion protein. The LAP score, leukocyte alk-phos score, is high in a leukemoid reaction versus low in a CML. And neutrophil precursors, there's more mature precursors, so you'll have metamyelocytes in leukemoid reaction versus less mature, immature neutrophils in CML, so you'll have myelocytes in that case. And then absolute basophilia is only present with CML. It's not present with leukemoid reactions. So late neutrophil precursors are metamyelocytes and bands. Remember, bands are baby neutrophils. Early neutrophil precursors are promyelocytes and myelocytes. In CML, that's usually found on routine blood work in asymptomatic patients, but it can also be present with fatigue, weight loss, night sweats, or abdominal fullness, such as splenomegaly. They can also have thrombophilias and anemia, which is common. Next up is Polycythemia Vera. In Polycythemia Vera, manifestations would be an increase in blood viscosity, also hypertension, erythromyalgia, which is burning cyanosis in the hands and feet. They get transient visual disturbances and an increase in red blood cell turnover, and this is seen in gouty arthritis. There's also aquagenic pruritus, as well as bleeding. And on exam with Polycythemia Vera, they have facial plethora, which is a ruddy cyanosis, a ruby complexion, splenomegaly, and on labs, you'll see elevated hemoglobin, leukocytosis, and thrombocytosis. There's a low erythropoietin levels as well, but the the oxygen saturation is normal. Also, Polycythemia Vera is a JAK2 mutation positivity. Complications of Polycythemia Vera would be like thromboses, so myelofibrosis and acute leukemia, and the treatment is through phlebotomy, as well as hydroxyurea if there's an increased risk of thrombus. Next up is obstructive sleep apnea. The pathophysiology here is that there's a relaxation of the pharyngeal muscles that leads to closure of the airways. It could be due to loud snoring and periods of apnea. Symptoms would be daytime somnolence, so they'll give you in the vignette the patient's been sleeping during the day or sleepy. There's a non-restorative sleep with frequent awakenings and morning headaches, and it's affective and cognitive symptoms. And the sequelae would be like systemic hypertension and pulmonary hypertension, as well as right heart failure. Chronic hypoxemia is going to lead to the kidneys producing erythropoietin, and that increase in erythropoietin leads to the polycythemia. Then next topic is androgen abuse. So there's clinical features of androgen abuse. We have the types of androgens, which is exogenous androgens, synthetic androgens, and androgen precursors. So exogenous androgens would be like testosterone or replacement therapy. Synthetic androgens would be like stanozolol or nandrolone. And then you have your androgen precursors like DHEA. And side effects of androgen abuse would be in men, reproductive men, would be that they have decreased testicular function and sperm production, as well as gynecomastia. In women, clinical presentation would be acne, hirsutism. They have deepening of the voice, as well as menstrual irregularities. Cardiovascular changes would be like left ventricular hypertrophy, as well as hepatotoxicity. There's possible decreases in HDL, and there's an increase in LDL. Psychiatric effects would be aggressive behavior in men, as well as mood disturbances, and hematological effects would be polycythemia, as well as possible hypercoagulability, with an increase in hematocrit and hemoglobin, which are dose-dependent. Next up would be hereditary hemochromatosis, and the clinical manifestations here of hereditary hemochromatosis can be seen in the skin, in the musculoskeletal system, gastrointestinal system, endocrine, cardiac, and infectious causes of hemochromatosis. So in the skin, you'll see hyperpigmentation, as called like bronze diabetes. Musculoskeletal would be arthralgias or arthropathies, as well as chondrocalcinosis. GI manifestations would be elevated hepatic enzymes with hepatomegaly early on. Later, they'll show up with cirrhosis, and there's going to be an increased risk of hepatocellular carcinoma. Endocrine causes diabetes, like we said earlier, the bronze diabetes, secondary hypogonadism and hypothyroidism. Cardiac causes would be restrictive and a dilated cardiomyopathy, and as well as conduction abnormalities. As well as infections, patients with hemochromatosis are at increased susceptibility to listeria, to Vibrio vulnificus, and Yersinia enterocolytica. So the initial diagnosis is going to be based on elevated iron studies, and it's confirmed by genetic analysis with the HFE mutation. That's just easy to remember, HFE, because Fe is like iron, so hemochromatosis, maybe. That's how I remember it. Okay, so serial phlebotomy can also significantly decrease the risk of cirrhosis and hepatocellular carcinoma. Next would be superior vena cava syndrome. It's more than 60% of cases are going to be due to lung cancer, especially small cell lung cancer, and non-Hodgkin's lymphoma as well. Other causes would be fibrosing mediastinitis due to TB or histoplasmosis, or it could be thrombosis due to an indwelling central venous device that can cause superior vena cava syndrome. When there's a history of a pulmonary embolism that's suggestive of superior vena cava syndrome, then you do a chest x-ray to identify the cause in 80% of cases. Then if there's an abnormality, you have to do a chest CT and a histology to determine what type of cancer you're dealing with and to guide the therapy. Next up would be head and neck squamous cell cancers. These are hard, unilateral, non-tender lymph nodes. Those are always suspicious of cancer, and you must evaluate them immediately. Biopsy the lymph node, and if there's squamous cell carcinoma, you'll require a pan-endoscopy, which is esophagoscopy, bronchoscopy, and laryngoscopy, and those are the best initial tests to look for primary sites. Then a biopsy is used when primary tumors is detected and gives histological diagnosis. There's an importance in determining the proper management and the prognosis. Head and neck squamous cell cancers, also they present with a history of smoking and alcohol use. They have lymph node enlargement of the submandibular or cervical regions. Those are highly suspicious of head and neck cancers. The majority of cancers in the neck and in the head are of squamous cell carcinoma. And if that's the case, you want to promptly biopsy them to do a complete evaluation. And the treatment of the head and neck cancers is going to depend on the stage, on the grade, and on the histology of the tumor. Various treatments options would be like radical neck dissection, tumor resection, platinum-based chemotherapy, as well as radiotherapy and palliative management. If there's an adenocarcinoma on lymph node biopsy, then you also want to consider breast cancer and you want to perform further tests. Next up would be prostate cancer. So prostate cancer, localized prostate cancer, requires radical prostatectomy. And in cases of recurrences of PSA later on, a salvage radiation therapy can provide long-term disease control for localized recurrent diseases. Salvage treatment is defined as a form of treatment that's given when the standard treatment has failed to control the disease. If there's a limited disease, then a non-steroidal anti-androgen like flutamide, along with a LHRH agonist, will prolong survival. But there's no demonstrable benefit in patients with orchiectomies. Estramustine, which is a combination of estrogen and nitrogen mustards, have a 40% response rate in castrated men, but it's not well tolerated by men with cardiovascular disease or hematopoietic disorders. And then radiation therapy is the best management for progressive pain in patients with prostate cancer. And bony metastasis is after androgen ablation. So like an orchiectomy, radiation therapy would be the best for management. If there is metastasis that is localized to a few sites, then focal external beam therapy is going to be mostly appropriate in that case. Next up is spinal cord compression. So in spinal cord compression, the causes here would be spinal injury, like a motor vehicle accident, malignancies like lung cancer, breast, prostate cancer, melanoma, and as well as infections that can be like an epidural abscess. Signs and symptoms of spinal cord compression would be a gradual worsening severe localized back pain, and the pain is worse when the patient is in a recumbent position at night. So early signs would be symmetric lower extremity weakness. They can have hypoactive absent deep tendon reflexes, and later signs would be a bilateral Babinski reflex, decreased rectal sphincter tone, paraparesis and paraplegia, as well as increased deep tendon reflexes and sensory loss. And the management of spinal cord compression is an emergency MRI, IV steroids, and radiation, oncology, and neurosurgery consultations. So in an epidural cord compression, you want to suspect epidural spinal cord compression in a patient with a history of malignancy. That's 60% thoracic and 30% lumbosacral involvement. There's a lung, breast, and prostate, and multiple myeloma are going to be the most likely tumors that causes an epidural spinal cord compression. Early on, a diagnosis is less neurological involvement. That's a better outcome. Although an MRI is important, but IV steroids should not be delayed. There's a decreased vasogenic edema caused by obstructed epidural venous plexuses that help alleviate pain and may restore neurological function. So you want to perform an MRI, an ESCC will confirm it, and then a neurosurgical consultation. Radionucleotide bone scans and skeletal surveys, as well as x-rays of the major bones, are used to detect bone metastasis, but not the thecal sac compressions, so it's not really recommended. Next up is tumor lysis syndrome, and tumors with high cell turnovers are likely poorly differentiated lymphomas like Burkitt's lymphoma and leukemias, particularly ALL and very rarely AML, will all cause tumor lysis syndrome. So metabolic abnormalities associated with tumor lysis syndrome include an increase in phosphate, and that's due to an intracellular electrolyte that is seen when the cells break down, and then the phosphate comes out, so you get high phosphate, hyperphosphatemia. You get hypocalcemia, and that's released phosphate is going to bind to that calcium, causing hypocalcemia, and that also occurs due to a release of intracellular products by the cell breakdown. Also, in tumor lysis syndrome, there'll be an increase in potassium. Potassium is an intracellular electrolyte, and then when the cell lyses and spills out, potassium spills out. And then uric acid also is increased due to the degradation of cellular proteins that causes a buildup of uric acid. So allopurinol is then given to prevent acute urate nephropathy, but it doesn't prevent the tumor lysis syndrome. It just prevents the urate nephropathy. So prompt identification and immediate treatment is necessary, as it can lead to fatal arrhythmias because of the hypercalcemia and the uric acid breaking down the myocardium, right? So they'll have a predisposition for fatal arrhythmias and even acute renal failure and sudden death. So the next one would be cancer-related anorexia and cachexia syndrome. This is called CACS. It's a hypermetabolic state. It's associated with weight loss, anorexia, and excessive reduction in skeletal muscle. The weight loss is going to be multifactorial, and it's due to a systemic inflammation and caloric reduction. The treatment here would be nutritional counseling and supplementation with enteral or parenteral feedings doing little to reverse the CACS, the cancer-related anorexia cachexia syndrome. Pharmacological intervention with progesterone analogs like megestrol acetate or medroxyprogesterone acetate can be given, as well as glucocorticoids, and these are effective at increasing the appetite. There was a mnemonic to remember megestrol to increase appetite. It's Meg will beg you for food. They'll make you so hungry they'll beg you for food with megestrol. So that's kind of cool. It's effective at increasing appetite, causing weight gain, and improving well-being. And in patients with longer life expectancy, progesterone analogs are even better than steroids, and that's due to the side effects being less with progesterone analogs. And then synthetic cannabinoids are also useful in HIV cachexia, but it's not effective in cancer-related anorexia cachexia syndrome. Next up is pain management in cancer patients. There's 3 key principles to the use of pain medications in patients with terminal stages of cancer, and those would be 3 of them. So you want to try non-narcotic measures first, unless you are sure that you're using your clinical judgment that the patient's in severe pain. Number 2 is that you do not want to be afraid to give narcotic analgesics, and you also want to prescribe adequate amounts of medication. You initially treat with a dose of short-acting morphine, and then you want to do a subsequent dose that's titrated as needed to achieve a complete pain control. Once that dose is established, and the patient can be switched on to a long-acting narcotic, and then a short-acting morphine is going to be used for breaking through the pain. Chemotherapy-induced nausea and vomiting management is the next topic. So in the absence of increased lipase levels, there's rebound and guarding on abdominal examination. Presence of bowel wall movement or bowel movement causes a diagnosis of pancreatitis. So perforation and abdominal obstructions are going to be less likely. Dry mucous membrane suggests volume depletion, so you want to give IV fluids first line, and then you want to treat the nausea and vomiting. So first, give them fluids, then the nausea and vomiting. Serotonin receptor antagonists like ondansetron, these are the best therapies for chemo-induced nausea and vomiting. Remember that mnemonic, feeling queasy at a party, keep on dancing with ondansetron? That's why. It's for nausea and vomiting. It targets serotonin receptors, and there's low side effect profiles, and it's very efficacious. Acute management, sometimes prophylaxis is used in combinations with steroids. Dopamine receptor blockers like metoclopramide and prochlorperazine are second line or even third line for refractory vomiting. And GI-specific opioid blockers such as methylnaltrexone, those reverse opioid-induced constipation. So that's interesting. It's methylnaltrexone. It's a GI opioid that reverses the constipation caused by opiates. Okay. Now, next we're going to talk about heparin-induced thrombocytopenia. We're going to talk about HIT 1 and HIT 2. So type 1 HIT, or heparin-induced thrombocytopenia type 1, that's marked by a non-immune mediated platelet aggregation. It results in mild thrombocytopenia, and the platelets are rarely less than 100,000. It usually happens within 2 days of heparin initiation. So type 1 heparin-induced thrombocytopenia doesn't require intervention, and it doesn't cause side effects. The thrombocytopenia resolves on its own without having to stop the heparin. Versus type 2 heparin-induced thrombocytopenia, the signs would be suspected with heparin exposure more than 5 days, and they can have platelet counts that are reduced by up to more than 50% of baseline. There's arterial and venous thromboses, as well as necrotic skin lesions at heparin injection sites, especially in those who are receiving heparin subcutaneously, like enoxaparin. classically occurs at the abdomen injection site. So another one would be an acute systemic anaphylactoid reaction after heparin. So diagnostic evaluation of type 2 heparin-induced thrombocytopenia would be a serotonin release assay. That's how you would diagnose. That's the gold standard confirmatory test, a serotonin release assay. And you want to start treatment in suspected cases prior to the confirmatory tests. So the therapy here is, number one, you want to stop all heparin products. That's number one. Then you want to start a direct thrombin inhibitor like argatroban or fondaparinux, which is a synthetic pentasaccharide. You want to switch to warfarin once the platelet count has been increased to more than 150,000. Then thrombocytopenia is going to be a mild to moderate, which is around 60,000 platelets, with a minimum risk of bleeding. Severe thrombocytopenia has less than 20,000, but that's uncommon. A thrombosis risk is as high as 50% with untreated heparin-induced thrombocytopenia. There's venous thrombosis in the leg, in the heart, and in the skin at the sites of heparin injection. That's very common. Also, arterial thrombosis in the heart and the limbs and the CNS. And then heparin induces conformational changes to platelet surface proteins, platelet factor 4. It's a neoantigen formation and recognition by the immune system. The platelet count usually normalizes 2 to 7 days after you stop the heparin, so transfusion isn't needed unless there's continuous bleeding, and that's uncommon in heparin-induced thrombocytopenia. Then finally, we have warfarin-induced skin necrosis. Remember, that typically occurs within the first few days of therapy, usually at large leading doses. The test questions are always, why did they get it? And it's because the patient had a susceptibility due to an underlying protein C deficiency. It involves the extremities like the trunk, the breasts, and the penis, and marginates over periods of hours. If it's left untreated, it can cause an edematous, pruritic, and ultimately necrotic area. So you do want to discontinue warfarin immediately and administer protein C concentrate because that's what they're needing. They're deficient in protein C, so you give them protein C. Some quick definitions here. Adjuvant therapy, whenever you see that, adjuvant therapy is defined as a treatment that's given in addition to standard therapy. This would be the case if radiation therapy was given at the same time as a radical prostatectomy. So you do adjuvant, you're adding on to that therapy. Induction therapy is an initial dose of a treatment that rapidly kills tumor cells and sends the patient into remission. A typical example of that is used in acute leukemias. Consolidation therapy is typically given after induction therapy with multi-drug regimens to further reduce tumor burdens. An example is a multi-drug therapy after you do induction therapy for acute leukemia. And then maintenance therapy is just that. It's maintenance. It's usually given after the induction and the consolidation therapies to kill any kind of residual tumor cells, and you want to keep the patient in remission. So you want to maintain them in remission. Maintenance therapy. So that would be like a daily anti-androgen therapy for prostate cancer. Then you have, as we said earlier, adjuvant therapy is one that you give at the same time to help a therapy. The next one is neoadjuvant therapy, and it's defined as a treatment given before the standard therapy for a particular disease. This would be the case of the patient if the radiation therapy was given before the radical prostatectomy was done. So in adjuvant therapy, you're giving the radiation therapy while the radical prostatectomy is being done. In neoadjuvant, you do the radiation therapy before the prostatectomy. So it's like saying new adjuvant, so before. And then finally, salvage therapy is just how the name implies. Salvage therapy is defined as a treatment for a disease when the standard therapy fails, so you're salvaging whatever you can, such as radiation therapy for prostate-specific antigen recurrence after radical prostatectomy for prostate cancer. And that's the end of hematology for internal medicine. Next up is hematology and oncology and pediatrics. So we're going to start off again with anemia, iron deficiency anemia in children aged less than 2. The risk factors would be prematurity, lead exposure, infants who consume low iron formulas, infants that drink cow's milk, soy milk, or goat's milk before 1 year of age. Also exclusively breastfeeding after age 6 months. These are all causes of iron deficiency anemia in children less than 2. Toddlers also who consume more than 24 ounces of milk a day and less than 3 servings a day of iron-rich foods like meats and fortified cereals. Universal screenings would be a complete blood count in all children ages 9 to 12 months, and treatment would be to empirically give them a trial of iron supplementations, and you want to check in 4 weeks if the hemoglobin increases. If so, you want to continue oral iron therapy for 2 to 3 months after the hemoglobin normalizes to get those iron stores back to normal. Then the most common nutritional deficiency in children is iron deficiency, and infant iron stores are going to be affected by 3 things. It's either going to be affected by the mother's iron stores themselves, or a prenatal and perinatal hemorrhage, as well as gestational age of the infant at delivery. Term infants have sufficient iron stores for 6 months, but then after the 6 months, dietary deficiency becomes the most important cause of iron deficiency. Often it's caused by excessive consumption of cow's milk, and that's more than 24 ounces a day. And causes of anemia is going to be secondary to either low iron content of iron in the milk, or poor bioavailability of the iron that's in the milk, or there's an increased intestinal blood loss from cow's milk protein-induced colitis. Children usually are asymptomatic, and classic symptoms typically are absent. So the diagnosis is usually made on a CBC, and a peripheral blood smear usually isn't needed. So no further testing in patients with their classic presentation. All right, next up is anemia of prematurity. Anemia of prematurity is an impaired erythropoietin production, short red blood cell lifespan, or it can be iatrogenic blood sampling. Those are the etiologies of anemia of prematurity. Clinical manifestations would be tachycardia, apnea. They can have poor weight gain, but it's usually asymptomatic, and that's what you should know, that it's asymptomatic. Laboratory findings is low hemoglobin and hematocrit, also low reticulocyte counts. They can have a normocytic, normochromic red blood cell. And the treatment for anemia of prematurity would be to minimize blood draws, to give iron supplementation, and to give transfusions as well. Now, the red blood cell transfusions can be given if an infant is symptomatic, but it can be further exacerbated with erythropoietin suppression and a delay recovery. And then you want to give supplemental erythropoietin, but then again, that supplemental erythropoietin isn't very effective. So actually don't give supplemental erythropoietin in preventing the need of a transfusion. So number 1 is transfusion can be given if that is the requirement. So anemia of prematurity, that affects most preterm infants, and the severity and onset depends on the degree of prematurity. So normally erythropoietin declines after the delivery due to an increase in oxygen concentration within the tissues, and that leads to a decrease in reticulocyte count. That decrease in reticulocyte count decreases the red blood cells physiologically, and that occurs at 2 to 3 months in term. Preterm would be an early onset anemia within 40 to 50 days, and it's a diagnosis of exclusion. It would give you like hemolysis, hemoglobinopathies, enzyme defects, and infections, all those should be ruled out, actually. So once those are ruled out, since it's a diagnosis of exclusion, that would give you anemia of prematurity. Next up is aplastic anemia, and this can be acquired or congenital. Congenital causes are more common in children, such as Fanconi's anemia, which is the most common congenital cause of aplastic anemia. Acquired aplastic anemia would be a pancytopenia, in contrast, an aplastic crisis, which causes decrease in hemoglobin. So an acquired causes of aplastic anemia would be like drugs, like NSAIDs or sulfa drugs, chemotherapy as well, and chloramphenicol can all cause aplastic anemia. Toxic chemicals like benzene, glue. Benzene is an industrial chemical. There's also CCl4, carbon tetrachloride, I believe it's what it is. Phenylbutazone and insecticide. So benzene is a big one that causes aplastic anemia. Also idiopathic causes, viral infections as well, like HIV and EBV can cause aplastic anemias, as well as immune disorders and a thymoma. And it results from an injury to a bone marrow by ionizing radiation. So you want to suspect it in any child with pancytopenia and any kind of recent exposure to any of those things that I mentioned above: drugs, toxic chemicals, viral infections, immune disorders, thymomas, etc. Okay, next up is Fanconi's anemia, which is an autosomal recessive or X-linked with clinical findings. So it could be, the clinical findings and manifestations are dependent on the location. So if it's in the bone marrow, then the aplastic anemia and progressive bone marrow failure is seen. Appearance would be a short stature, microcephaly, abnormal thumbs. Fanconi's anemia, I remember, has that, I think it's a biphalangeal, triphalangeal thumb, but it's a thumb with two thumbs inside of it. So it's kind of weird, and it kind of looks like, so that's what it is, a Fanconi's anemia. Sorry, I was thinking triphalangeal thumbs is diamond black fan, I remember. So it's another fan, but no, this is sorry, don't get confused there. That's a diamond black fan. This is Fanconi's anemia, completely different. All right, so appearance: they're short stature, microcephaly, they have abnormal thumbs, and they have hypogonadism. On the skin, they have hypopigmented and hyperpigmented areas, as well as cafe au lait spots and large freckles. And the eyes and the ears, you'll see strabismus, low-set ears, and there's a middle ear abnormality like hemorrhage or incomplete development. There's chronic infections and deafness. All those can be associated with Fanconi's anemia. Other characteristic congenital abnormalities such as eye or eyelid changes like microphthalmia, upper limb abnormalities like absent thumbs. They can have skeletal abnormalities and renal malformations, such as a horseshoe kidney. Those can also be present in Fanconi's. Also a progressive pancytopenia and macrocytosis. The blood counts start to decrease between 4 to 12 years of age, and the average age of the diagnosis is 8 years old. And initial manifestations is usually going to be thrombocytopenia, and that's followed by a neutropenia and an anemia. Most children are going to be diagnosed by the age of 16, and they have a predisposition for cancer. And the pathogenesis is numerous genes are all believed to be involved in DNA repair and have been implicated. So the diagnosis would be chromosomal breaks on genetic analysis, along with clinical findings. The definitive treatment would be a hematopoietic stem cell transplant. Next up is finally the diamond black fan anemia. This is what I was getting confused with. Okay, this is also known as a congenital pure red blood cell aplasia. Signs and symptoms is present within the first 3 months of life, and they show up with pallor and poor feeding. More than 90% of cases are diagnosed within 1 year of life, and within an average of 3 months. You want to suspect diamond black fan anemia when they have a normocytic or macrocytic anemia, but it's not megaloblastic or as the neutrophils. So it's macrocytic but not megaloblastic because the neutrophils are normal. They also have reticulocytopenia and congenital abnormalities present. So more than 50% of the cases, they have a webbed neck, a shield chest, so that can start looking like Turner's, right? They have a cleft lip, but here's the thing, they have the triphalangeal thumb, like I said earlier. That is a thumb that is so wide, there's like two or three thumbs within one thumb, and that's kind of weird, and it's unique, so because of that, it looks like a fan. So that's how I remember it, diamond black fan. Black fan. Go figure. That's the way I remember it. And these are present. And they will tell you that. There's no other way around it. White blood cell counts and platelets are going to be normal. Majority of cases are going to be sporadic, so 15% may have a dominant or recessive inheritance. Primary pathology is that it's an intrinsic defect of erythroid progenitor cells causing an increase in apoptosis, which is programmed cellular death, and electrophoresis, which increases hemoglobin F. There's normal chromosomal studies, and the treatment is mainly based on steroids, and non-responsive patients who don't respond to steroids, will require a transfusion. All right, next up is transient erythroblastopenia of childhood, or that's TEC. That's an acquired pure red blood cell aplasia and occurs in children between the ages of 6 months to 5 years of age. Most cases are going to be diagnosed after their first year of life, and there's no associated congenital abnormalities. They have a gradual onset with pallor, and there's a decrease in activity. On physical exam, they're unremarkable except for the pallor and tachycardia, and on labs, you'll see a normocytic, normochromic anemia without any type of macrocytosis. The hemoglobin ranges from 3 to 8, and there's extremely low reticulocyte counts. So following along, we have neonatal polycythemia, and by definition, this is a hematocrit that's more than 65% in term infants. Causes would be increased erythropoiesis from intrauterine hypoxia. There could be maternal diabetes involved, maternal hypertension, smoking, or intrauterine growth restrictions. Erythrocyte transfusions would be like delayed cord sampling, or delayed cord clamping, and common causes there would be like an excessive transfer of placental blood when the cord is delayed and being clamped. You have too much blood getting in there and you get polycythemia. Twin transfusions as well. And then on clinical presentation, they present with a ruddy skin, hypoglycemia, respiratory distress, cyanosis. They can have apnea, irritability. They can be jittery, which is actually the most common manifestation, and abdominal distension. And the treatment here would be a partial exchange transfusion. So you want to remove the blood and infuse normal saline. And the reason why you do that is you do it when the neonates are symptomatic. Asymptomatic neonates will only need hydration by a feeding or parental fluids. And then most neonates are asymptomatic other than appearing ruddy or plethoric. As the hematocrit increases, there's going to be an increase in viscosity, and that impairs blood flow to various organs. Then that increases the red blood cell mass, which then increases the uptake of glucose and calcium by the cells, and then causes hypoglycemia as well as hypocalcemia. Moving on, we have in immunodeficiencies, we have Wiskott-Aldrich syndrome, and that's an X-linked recessive defect in the WAS protein gene, which impairs the cytoskeleton changes during cell signaling in leukocytes and in platelets as well. Clinical features will have eczema, they can have microthrombocytopenia, and the clinical findings there, they can range from petechiae to purpura to a severe bleeding like intracranial hemorrhages, hematemesis, and hematochezia. So they'll have small platelets, they'll have low platelet counts, and they also can have recurrent infections with bacterial, viral, or fungal. Treatment here would be stem cell transplant for Wiskott-Aldrich syndrome. So the WAS gene that's found in hematopoietic stem cells, it's an autoimmune disorder that occurs in most patients with the WAS gene. And then eczema, that's the most common feature. Hemolytic anemia as well, arthritis and vasculitis can also occur. And the diagnosis is made clinically, but gene testing does allow for screening of other family members. Moving on, we have tumors in children. The Wilms tumor, or the nephroblastoma, that's the most common renal malignancy in childhood, the fourth most common childhood cancer, and a peak age is between 2 to 5 years of age. It's usually sporadic, and it's associated with three syndromes: the Wagar complex, the Beckwith-Weidman syndrome, and Dennis-Drash syndrome. So you have your Wagar complex syndrome, which is stands for Wilms tumor, aniridia, genitourinary abnormalities, intellectual disability, which is the mental retardation, the Beckwith-Weidman syndrome, and the Dennis-Drash syndrome. Clinically, they are asymptomatic, and it's incidentally found by the caretaker, the physician. Some may develop abdominal pain, hypertension, hematuria, or fever. It's a firm, smooth abdominal mass that doesn't cross the midline. And the treatment would be to remove the tumor through excision or nephrectomy. You can give chemotherapy with or without radiation, and the prognosis is usually around a 5-year survival rate and with treatment. So a 90% survival rate, especially if they catch it early. This usually affects one kidney. Less than 10% of them are going to have bilateral involvement, so unilateral is most common. It commonly metastasizes to the lung, and children will rarely present with pulmonary symptoms because it's caught earlier than when they metastasize. The management first step would be to do an abdominal ultrasound, and that differentiates a Wilms tumor from another abdominal mass. And then you want to follow that up with a contrast CT of the abdomen, which evaluates the nature and the extent of the mass, as well as the chest to identify pulmonary metastasis. Next up, you have neuroblastoma. That's the third most common tumor in children after leukemia and brain tumors, but it's most common in the first year of life. It arises anywhere in the sympathetic chain, but most commonly it's found in the adrenal glands. It'll show up as an abdominal mass that does cross the midline, and they present with systemic symptoms. A primary brain tumor of childhood, most common solid tumors in children, and second most common tumor in children after leukemias. Remember, ALL is the most common out of all of them. Okay, following along, we have manifestations of central nervous system tumors by location. So it's either supratentorial, the posterior fossa, brainstem tumors, or spinal cord tumors. So in supratentorial tumors, manifestations would be like increase in intracranial pressure, seizures, weakness and sensory changes. So they'll have morning headaches, vomiting, papilledema, macrocephaly whenever you have increase in intracranial pressure. Posterior fossa tumors as well, increase in intracranial pressure, but this time they have ataxia because it's posterior, it affects the cerebellum, right? Clumsiness, and that's cerebellar dysfunction. Brainstem would be ataxia, clumsiness, and central cranial nerve palsies. And then spinal cord manifestations would be back pain, weakness, and abnormal gaits. Then you have a pilocytic astrocytoma, which is a low grade. It's the most common brain tumor in children, the astrocytoma. The symptoms depend on the tumor location, but they're all going to increase intracranial pressure, regardless of the location, because the tumor size is so big. Mostly it causes symptoms due to local pressure, and it doesn't undergo any kind of malignant transformation. Pineal gland tumors, or pinealomas, are located in the quadrigeminal cistern, and that produces melatonin. So remember, quadrigeminal cistern, that's in charge of melatonin. It's a rare tumor, and germ cell tumors account for the majority of those pineal tumors. So pineal gland, remember melatonin. Serious complications results from a mass effects. Okay, so what are some of the clinical features of the pineal gland masses? They can have Perinaud syndrome, which is a dorsal midbrain syndrome, and that presents with limited upward gaze. The eyelid retraction is the upper eyelid that's retracted. That's called the Collier sign. And the pupils are not reactive to light, but they are reactive to accommodation, and that's known as a light-near dissociation. Obstructive hydrocephalus, that shows up like papilledema, headache, vomiting, as well as ataxia. And this is because the obstructive hydrocephalus blocks the aqueduct of Sylvius. And that's it for tumors for pediatrics. Now, for surgery, hematology and oncology for surgery, this one's a little bit short. And so we have anterior mediastinal masses. The differential diagnoses are going to be the 4 T's, right, for the mediastinal masses. The teratomas, the thymomas, a thyroid neoplasm, and the 4th T stands for terrible lymphoma. So remember that for differential diagnosis is for anterior mediastinal masses. For testicular tumors are divided into germ cell tumors and non-germ cell tumors. Under non-germ cell tumors, you have your Leydig cell tumor, your Sertoli cell tumor, and your testicular lymphoma. Now, germ cell tumors are divided into seminomas and non-seminomatous tumors. So seminomas, and non-seminomatous tumors are going to be further subdivided into yolk sac tumors, which is an endodermal sinus tumor. You have choriocarcinoma, that's a non-seminomatous tumor of the germ cell tumor, which is a testicular tumor. Teratomas, that's the one that's going to have calcifications. You're going to see a tooth in there and hair and nails and stuff. And embryonal carcinoma. So seminoma versus non-seminoma is a serum hormone level is going to be helpful in distinguishing seminoma versus non-seminoma. A seminoma is going to have a serum beta HCG level that's increased in 1/3 of patients, and alpha fetoprotein levels are essentially normal with a seminoma. In a non-seminoma, most of them have an increase in alpha fetoprotein. And they also have considerable amounts of increase in beta HCG, and that can be present in the form of a mixed germ cell tumor. And then finally, a teratoma, that can be distinguished from other germ cell tumors by the presence of fat or calcium, especially in the form of a tooth, like we said earlier. Okay, and then we have the hematology oncology section for OB-GYN. So here we talk about RH alloimmunization. So alloimmunization, like sensitization, and examples to that would be anti-D antibody titers. Those occur when the mother is RH negative and then has a baby who is RH positive. So whenever you see a RH negative mother in the vignette, just start thinking alloimmunization problems there. So to prevent the maternal immune system from developing anti-D antibodies, anti-D immune globulin is given given first at 28 weeks gestation, and then you want to repeat that at 72 hours of delivery. So about 3 days after she gave birth, give her another alloimmunization with anti-D. The standard dose is going to be 300 micrograms at 28 weeks, and can usually prevent alloimmunization, as the risk of alloimmunization is very low before 28 weeks. If the patient does develop placental abruption, undergo amniocentesis, chorionic villus sampling, and external cephalic version earlier in the pregnancies, then you want to do a KB test to determine how is the dose going to be given, how much dose of anti-D should be given. And if they don't say KB test, KB stands for Clive-Howard-Bethke test. They could ask you that way. So around 50% of Rh negative women will need higher doses after the delivery if they have placental abruption or if they have any type of surgical procedure. The Clive-Howard-Bethke test or the KB test is commonly used to determine the dose. So if they ask you, how are you going to determine what dose to give them? It's the KB test, and that's usually done after the delivery. So if they're asking you, they're going to either ask you about the KB test for dosaging after the delivery, or they're going to tell you when to do the anti-D immunoglobulin, and that would be at 28 weeks. And here, ABO alloimmunization, an O-positive mother and a father who has AB positive has a less severe hemolytic disease of the newborn as compared to Rh incompatibility, as varying titers of IgG antibodies are formed and IgM antibodies are also formed. Titers can be very high in certain populations like Africans and African Americans, leading to severe disease. Otherwise, less severe disease may be asymptomatic or with mild anemia or jaundice in the newborn, and it can be usually treated with phototherapy alone. And only IgG can cross the placenta. So that's a nice little tidbit they'd like to ask. Only IgG. And that is the end of our hematology lecture.